3, okay. 4. Gloria, you'll be 1, 2, 3, 4. Very good. And please keep your number. When we move, please don't go and join someone because it's a friend and you want to be with the person. Keep your number and then we break into the various groups. So group 1, discussing strengths, will be led by Dr. Baba Tamwa. So Baba, please stay there. All those in group 1, please you move to that section of the room. Okay, move to that section of the room. The discussion will be facilitated by Dr. Baba Tamwa. You'll be looking at the strengths. And then Dr. Stephen Engman, weaknesses. Please, you move to this side, the middle part, okay, to discuss weaknesses. And then Dr. Van Dyke say, if you move this way, group 3, number 3, you come here to discuss opportunities. And then Dr. Dorak Norbert and the team, you move to the back, where Nana Pari and Co are to discuss stress. We'll have maximum 40 minutes to do this discussion, and then we'll come back. So within the group, the facilitators would appoint someone to record what will be discussed, and then we'll come back, and each one of you will present in 5 minutes, and we'll have a plenary discussion on it. So please, let's play group 1, Dr. Baba Tamwa 1. Everyone, please move to Baba. Group 1, we'll be discussing strength. Group 2, Dr. Engman, kindly into the middle of the table. We may have to rearrange it a bit, bring the tables and chairs around. Group 3, Dr. Van Dyke say, you come this way. All 3, kindly join. And then group 4, Red, you go to the back.
Break because of time. I don't know whether I could play music for. I don't know before. What did you say now? Did you
I want to overwhelmed. Unknown. Very
Hello. Hello. Yeah. Thank you all very much. Thank you very much. Perhaps the groups who have not disbanded yet, you can stay there, then you present from them. When you finish, you can return to your seat. Don't worry, you can stay wherever you are. You present and then afterwards you go back to your seat. All right, so thank you. We went round and we saw how engaging the discussions were. Group 4, please, you can stay there if you don't mind. When we are done, then you can come back to it. So the first group, led by Dr. Baba Damoa, looked at the strength. So as I indicated, the strength looked at the internal factors or the prevailing factors that can enhance our chances of engaging in collaborative research or enhance even the output if we are to engage in collaborative research. So is the rapporteur ready? You may not have to project, you can just read from the
main point.
Yeah, the main point. All right.
Thank you very much for the opportunity. Morning, everyone. My name is Cornelia from Group 1, and we analyze the strength.
Yeah, Cornelia, we can hear you.
You can hear me now.
Yes, better.
Good morning. My name is Cornelia Group 1. We analyze our strengths as methods when it comes to collaborative research. So, as we know, as family physicians, we have diverse knowledge, different backgrounds, and we are also widespread across the country as compared to the other specialists. So this is a very great strength we can call on. With regards to research, if you are doing a research on what topic in your locality, you can engage the other family physicians in other parts of the country to also help in the same research. So you have data that is of high quality from different regions, different age groups, use the kind of patients, and you're able to get very good data. It also cuts down on the time spent collating data, because you have various, because of our wide number, wide distribution, we can have a lot of people involved in data collection, and within a very short time get large volumes of high quality data. We are gatekeepers to our patients. Our patients come to us first. We can leverage on that as well. We can collaborate with other, we are getting clinical data, other specialties, to also get some information from them. For example, you have a patient who needs some surgery, collaborate with doctors wherever. You might be in, maybe in northern Ghana, you refer the patient to Accra for a specialized surgery. And call your fellow family physician, follow up, then get your data that you need for research. Collaborative research helps us, there's a financial benefit to it. So that's the first point, high quality data from our wide distribution. We are able to get more grants from institutions that give grants, from sister companies, etc., to help with our research. We have the big names within the society, people who are well known for their work in particular fields. So as new researchers, like with the young ones, we attach such names to our research. The credibility of that research goes up incredibly. They might not necessarily even be part of it, but just their name being on that research paper gives you some very good credibility. Then, again, with regards to that, both researchers who serve as mentors for new researchers when it comes. We have some recommendations as well. One of the recommendations, family physicians who are already doing lots of research, you mentor the younger family physicians and residents, also help them build capacity. Another recommendation is initiation of conversations regarding research should be bi-directional. We don't necessarily need to wait for our senior colleagues to approach us to join the research. We can also look at certain topics that yes, then speak up in conducting. The more methods we have, we are able to collaborate, come together, and get grants for research. Another recommendation is that data capture should be in real time or current, so the formulation of policies are actually what is needed at that point. Then data collected should be of high quality, and our training helps us to build long-lasting, or the nature of our job, we build long-lasting patients. So we should get the data in a way and manner with patients come back to us when we need further data for research. Thank you.
Awesome. Let's put our hands together for them. Let's put our hands together for them. Thank you very much. I captured one thing that we are sitting on a gold mine, right? That's our strength. All right, weaknesses. Group 2, led by Dr. Engman. Rapporteur.
The extensive weakness of great president. Our first weakness we identified was the lack of understanding of the research, starting from our weak foundation through medical school all the way through membership. Sometimes we don't understand it. We get to fellowship level where you have to really do the research. That's when you get to know how much you want to. Then our second weakness we identified is that as clinicians, we do a lot of clinical, which takes a lot of our time. So there's something collaborative research to require time. So sometimes we have this time, little time to dedicate for the collaborative research. Our third weakness was the lack of interest in the research, which is tied to sometimes low motivation in the research. We also identified that there is usually some challenges in acquisition of funds or in identifying resource areas where you can have funding to do the research. We also noted that there is lack of exposure to the research due to lack of mentorship. Sometimes we may have a topic, something that you want to do, but you don't even know, you are not exposed enough, so you don't even know how to go about it. We don't have much mentor to take us through the process. Now, our last challenge was because collaborative research requires a number of people from different sectors. Sometimes there are challenges in communication between the different people involved and how to get everybody on the same level, how to communicate between the people involved in the research becomes challenging. So those were the So our recommendations were that we should start training in research right from medical school and make the understanding clear so that even from medical school, if we start with a lower level of research as we are moving through membership, we are building our capacity moving on the ladder to higher and more support research in. And then our second recommendation was that you usually find time for what you think is important. So making time for the research will also be tied with how much interest that you feel the person to be involved in the research. And it will also be tied with picking topics that are of interest that have that much commitment to the research. And then we also spoke about full-time mentorship to help with the research process. There was also a challenge about on the motivation, and our recommendation was that if we see the research as something that we have also contributed in the clinical process, for instance, develop protocol that's being used in your facility to help manage people. That should be something that you have to see that you have contributed to clinical work in the form of report. And we also suggested that make people also more interested in research. If, for instance, benefits can be added to research, for instance, if you write a number of papers, membership or whatever level, maybe there should be some considerations in say reducing your number of years in training compared to somebody who didn't produce anything during the tenure. Maybe that.
All right, three. Opportunity.
So we looked at the opportunity, and we already know that the Faculty of Family Medicine has grown in leaps and bounds over the years. And we have family physicians all over the country. So that's already an opportunity that we can take advantage of. And also we used a practical approach to tackle this opportunities task. We started off by looking at where we are currently located as public institutions, and then to think out to look at possible collaboration. And in doing so, we identified that there are family physicians in government institutions, and, and starting from the teaching hospitals, we have Kolibu Teaching Hospital, Amale Teaching Hospital, you have 37 military hospitals. Then we also have academic sites like UGMS, KNUS, UDS, you have. Then also with the government structure, we have Ghana Health Service, Child, MOH, other government institutions that we could collaborate with, as well as PSOs. Then also we have private facilities, and then international facilities. And in the collaboration, we could look at it or tackle it at the level of teaching hospital with academic institution, teaching hospital with another teaching hospital with international organizations, or government with another, and so on. And so we went ahead to tackle it by looking at institutions. So we had one of us from Sunyani Teaching Hospital. For the government side, we identified Holy Family, Techiman government, the district hospital, and we also had SDA hospital, which is the child institution. Sunyani Teaching Hospital is part of it. Then the University of Natural Science, the academic for the second example, one of us was also coming from a multinational or international group. So we had SafeCare, and they focus on health system strength, QI, and other collaboration. Yes. So we identified collaborations they have actually been doing over the years with institutions like Ghana Health Service, National Health Insurance, value-based care, and CHA, HEFRA, then also with academic institutions like the University of Ghana. And surprisingly, it wasn't just with the health or medical institutions, but business school, economics, school of economics, and then pharmacy, those collaborations. So it's an eye opener. Then also you have school of medicine. Then another opportunity, we looked at one of us from Ashanti region, from Wayne government. And collaborations we identified were just government hospital driving, KNUST, CAD, and then surprisingly, Ashanti, there are about 20 or more medical students who happen to be family physicians. And so there could be collaboration across all those institutions. In academia, we have SNS as well. Then another opportunity we looked at was School of Medicine you had. So that was an academic institution. And for the collaborations, we saw that they were collaborating within the university itself, with the pharmacy, and then that department of pharmacy, and then Institute of Research, which really helps them streamline their research. Then with the government, we have a whole teaching hospital. So, Papa, we're trying to remember your hospital, but a place with a public physician in the locality. And then we also have a family physician at Aflao, a private facility. And internationally, there are collaborations with Michigan University, Johns Hopkins, Yonsei University, South Korea. And so those were collaborations we looked at. Then there was also UPS, also from the teaching hospital and academia aspect. We looked at their collaborations within the institution. Then we had a private perspective also. So we had one of us from Yahoo Medical Center. We looked at other institutions within that locus, 7 similar clients. So Accra Medical Center, Trust Hospital, Bank Hospital, it could be collaboration there. Then with academic institutions, we have UGMC, quite good, teaching hospital in Greater Accra Regional Hospital. Then they also have satellite from Yahoo, one of which is Sakuradi. Then there's also one at Accra that they could be collaborating to have research. Then Temaport, we had one of our matured members also telling us how opportunities have gone by because we've never thought of research as something we could do. So some of the areas we looked at were private funds. There are quite a number in the Tema area with schools, nursing schools and others. So Nabita, Maritime, and others have, and then especially with the Tema location, there are lots of family physicians in the occupational health aspect. And we could also take advantage of that to do collaborative research in that aspect. Then there's also Ensign Public Health Training Institute within that local site. So after looking at all these opportunities, we make some recommendations. The first we thought of was that we need to do a mapping or get a directory of where all family physicians are located in the country so that it will be easier to form collaborations with them and regularly update this database as we get new platforms. Then we also looked at a seminar. First, the example was private activities. Stretch it to involve in all the areas we have identified to educate and encourage collaborations in research. And then we'll generate problem lists that are based on gaps that we've identified wherever we find ourselves. And then we look at general challenges that we are also facing, that we feel we can, through research, come up with a possible solution. Then pinpoints can also be ways of generating research. Things that are really so disturbing the systems we work with. We are tired of working with things. What's my solution? It would be a way of generating. Then we could then look at how we would make these changes and prioritizing them as we do. Thank you.
Excellent. Well done. Let's put our hands together for them again. Well done. You're allowed to form, discuss, threads. Before discuss threads. Okay.
Good morning. I make this presentation on behalf of the group 4. We are talking about threats and definitely it's related to internal. So please bear with me as I discuss. Our first point is lack of recognition of family medicine or family medicine institutions or family physicians of who we are and what we do. Still under this point, we have challenges with some institutions having different perceptions of who we are. Then we talk about lack of priority. Different levels of priorities by different partners in research. So in this case, if there is an institution that is interested in a particular area in research and family medicine, family physicians can help, or the organization of family medicine or physicians can help. If our priorities doesn't really match or does not meet their own, it will be hard for them to join us to conduct research in such an area. And then there's also a problem for financial contribution and maybe improper disbursement of funds, and then poor or lack of logistics to support family medicine or family physicians from the community level, from national level, or by other institutions that are interested in conducting research. And there is also a problem of time management. This is a very big threat because of the responsibilities and roles carried by family physicians or organizations that have family medicine doctors working in. Because if you're a family physician and you are in a facility that probably conducts research, once in a while you have an opportunity to take part of the research. But if you happen to be very few and you are frontliners, you will not have such an opportunity, even if the research is being conducted in your facility. It will be very difficult because at that moment you are being pulled to certain departments or units that need your services and even follow up. We also have a challenge in interest of research being endorsed by other research institutions. So some institutions are not interested in research. Some agencies are not interested in research, but family physicians and family medicine organizations can be of great help. So should they know or should they have interest in it, they can probably be encouraged or they can call on us all the time for proper collaboration. And then we all know about bureaucracy. If you have maybe some investors or some researchers from other countries coming into this country, or even within this country, if you have someone wanting to partner us to conduct a research, you know all that we have to pass through, level by level, but unfortunately, some levels may be very difficult. That will take so much of your time. If you don't take care, you lose interest in the research. And then we have also noted down that there are some agencies that have their own interest in the research. So if they're coming to contact you as a family physician, and actually their interest is not so much towards patient health and development, but towards their market, their product or their definitely will be interested in the research, but not towards that skewed interest that or the interest or the topic in which they propose towards the research. Example is if maybe an organization, but if we have an organization that likes to encourage intake of some beverage, and maybe they want to conduct their research, they may contact you. But if you go down in detail with them and they explain to you what they are interested in, maybe their benefits, but you realize that this product has an agent that will not be beneficial towards your patient development or health. You will not be able to, you can help maybe the knowledge, but you will not be able to take part or collaborate with such an institution. And another threat, policymakers, some policymakers who are actually not interested in research, and therefore they cannot appreciate research. So they cannot even encourage collaboration between family medicine and their agency. So they cannot help you with funds, they can't help you with logistics. I want to mention out the short recommendations. In case of lack of recognition, definitely there must be increased awareness and knowledge of what family medicine is to all people, national, community level personnel. And then must prioritize there must be increase in prioritization of collaboration with family medicine personnel or organization when it comes to research. everyone's interest in research must be increased through leadership and then mentorship, whether in training or service. There must be improvement in financial support towards collaboration in research. And then in terms of time allocation, please, definitely, we all do projected expectations for the year or plans for the year. So whether you are into academics or you are into service, I think there must be a number of research that you need to conduct through collaboration, so that by the end of the year, you'll be able to have time for your research and then service or training, you will also be able to take part. There must be clear understanding and definition of roles before and during research collaboration. They also encourage that institutions that pose threat to family physicians or family medicine when it comes to research should be discouraged, so that bureaucracy will also be discouraged. And then lastly, when we talk about the expected results in research, I think that, as we all know, statistical significance cannot be taken over clinical significance. So when we are doing we are going to do collaboration, we should not encourage maybe the market people who are into marketing of their beverage to get more finance, can't encourage their interest or take their interest over patient health and benefit. And in that case, policymakers should be what? Stimulated to be interested in research, so that even when we are not contracted in such areas at the ministry or any level, they will also prioritize patient health and development. Research should be a requirement for career progression. And then we must propose a clear-cut role, especially in conceptualization of what the research is about, so that at the end of the day, community, regional, and then national level personnel will all benefit. Thank you very much.
Thank you very much. Let's put our hands together for everyone. Thank you, Group 4. Thank you, Group 1, 2, and 3. For me, I think it's been quite revealing, some of the things that have been shared. But most importantly, moving forward, this is not just going to be a talk show, but for the fact that we have very important stakeholders here, we have a former chair of the faculty, a current chair of the faculty president, we have the support president and chief executive, and we are family medicine in Ghana. All of us together here at family medicine Ghana. So the things that we've discussed, I'm going to take it up myself, and of course, in collaboration with all the stakeholders to ensure that going forward, we'll be able to implement the recommendation. And of course, look at our strengths, our weaknesses, opportunities, and the threats that can mitigate against that in achieving collaborative research. On this note, please, is there anyone who wants to add something to this before I hand over the mic to the chair of the session? Yes, Prof. Suman has something to say.
Thank you very much for just by way of information. I think that this workshop is very useful. We all have to be aware of what is happening on the continent globally. I think everyone was mentioned. I don't know how many of us president are aware of AFRIN, which is the Young Doctors Group of Africa. They're having this sort of research collaboration that's ongoing. So that's an opportunity for president. Then also attending our conferences, Prima Ahmed Conference, Prima Ahmed in the Education and Research Wing of Africa. And when you go to such conferences, visibility are almost nil. It's always the same faces you see. But writers for presidents, that posters, quality improvement projects, etc. that you can protect. And interacting with colleagues from other confidence. And we can also start here, or maybe continue from what the work we are doing over here. We reorganize our support conferences such that but we can still be workshop sessions on vision and research, sessions so that in time that we build that. So this is just what let's be a bit more visible. Yeah, we are enjoying fellowship in Ghana, but let's move on. So let's see. Thank you.
Thank you very much. On this note, I hand over to Dr. Aye.
Thank you very much. We shall reserve more comments for the question which is start. So far, so good. Dr. Isi Boateng, thank you very much. We didn't stick to our time, but it's for useful activity. I look around and I see this group of ladies and gentlemen who look like high school, some like matrons with oversized uniforms. I'm rather impressed by the quality of the uniform. Now, this is linked to the next group or the next activity that we are going to do. I heard they are from Create. Can see on the pull-up over there, the Global Health Research Group on Collaborative Care for Cardiometabolic Issues in Africa. Now, led by our own Dr. Roberta Lamptey. Now, we all know him very well, a fellow, the West African College, fellow of the Ghana College, in fact, a dermatologist and a consultant physician at Kolegu Teaching Hospital. And, I'm not surprised he has pulled in the Leicester University because he's an honorary lecturer over there. Now, he is going to lead this group to handle the issue of create a feasibility study. Dr. Roberta Lamptey.
Thank you so much, Dr. Aye, for the very kind introduction. And it's always great to be here on the platform of Society of Family Physicians of Ghana. And I'm a proud one and a pioneer one, if I can step in the shoes of my boss, Professor Isuman. So today, we are going to tell you about the NIHR, an NIHR funded study called CREATE. CREATE stands for Collaborative Care. I think as family physicians, it's one of our core things. We believe in collaborating. So this is an original piece of work. It's been done in Ghana, Kenya, and Mozambique. And I am the principal investigator for the low middle income countries in Ghana as well. But I think the very best person to tell you a bit more about CREATE will be the team members without whom this would not be possible at all. So without much ado, permit me to call Dr. Banfu to take it up from here. Thank you.
Good morning. Good morning, ladies and gentlemen. So, as introduced by Dr. Robert Lamto, my name is Robert Branson Bambo, member of the Great Trial, and I'm here together with my team, with the trial manager.
Sorry for the interruption. Now there is a pharmaceutical group who have comparative level, and we just give them 5 minutes to do their presentation, whilst my high school people and the matrons are waiting. So just 5 minutes. Then, if you could quickly come over, just 5 minutes, not more than 5 minutes.
Good morning. Please, my name is Ebenezer Abinyam, a rep of Denk Farm. Over 30 years in Ghana, Denk has been with us, providing only quality medicines to clients or to doctors and patients alike. This morning, we want to briefly take this wonderful group through one of our products. But before then, we want to remind honorable doctors that our combination products are on the market, full Losartan, combination of Losartan and hydrochlorothiazide, 50, 12.5, 12.5 strength. So for patients whom we are giving the products or the molecules individually, this is a fixed dose combination that is really helping with compliance. We also have our perindopril Lodipine for the strengths are available for our clients. And then also our almighty Ambadem. Ambadem is a combination of amlodipine and Valsartan for that bioequivalent properties like the innovator brand. So we are giving a fixed dose combination, good combination at a relatively affordable price. So Ambadem 130, 160, then 160. This morning, we want to discuss what we call stopping the clots, the safe and convenient approach. Yesterday, we had a lot of sessions on anticoagulation. And then this morning, it will just be right that we continue with the product on anticoagulant. Coagulation has its own benefits. These are some of them. However, it may also present with some form of issues if they care at the wrong place. So they could also be life-threatening. And then this happens, and the manifestations, as we all know, stroke due to AFib, DVT, and then ACE-related PE. These are the dynamics of AFib-induced clots the system. Strokes due to AFib are more disabling and more painful than strokes with other causes. The dynamics of VT is quite invasive as far as diagnosis is concerned. So about 70% of PEs are detected at autopsy. So these are issues that clinicians are very careful to take note of. Once diagnosed, what are the what we do to improve patient outcome? So is the use of optimal anticoagulation. Coagulation is helping reduce the clot extension and also prevent the formation of new clots. Anticoagulation has traveled over 50 years. Mankind has been served with almighty warfarin for a very long time. But we all agree that it has come with its own challenges. So the need for regular monitoring, that's giving patients and clinicians a lot of stress, dietary medication adjustments and all that, and then the very high risk of bleeding associated with warfarin. So, of course, optimal anticoagulation is a balance between beneficial outcomes and the risk of bleeding. There is therefore then, because of these challenges, the paradigm shift. Why the shift? It's due to issues associated with warfarin, like we've said earlier. therefore the paradigm shift. So now clinicians are moving more towards safer anticoagulants than the warfarin. There's therefore an increase in the use of the direct oral anticoagulants in body medicine. That's what we can do. The question is why the shift? Cause to prevent you present with clinical evidence that it is also comparable or not superior to warfarin. It has convenience because there's no need for frequent monitoring and those adjustments. And then also the flexibility of options. So doctors can choose between most of the molecules that are under the group. So we at Denk Pharma, among the direct oral anticoagulants, what we are promoting, what we recommend is what we call Axaban-Denk. Axaban-Denk is Pixaban, the direct oral anticoagulant from Denk Pharma. So you are sure you are getting the quality that your clients deserve. So we have the 5 milligram talk and the 2.5 milligram strength available. But the product was launched 2023 June, and it's been on the market since, and patients are doing very well with it as we speak. So this Axaban-Denk, this is what it's used for treatment of VTEs and then also prevention of sickness. Of course, at Denk Pharma, we trust in the product that we have, so we give quality. And therefore, we say that we conduct our bioequivalence studies that is comparable to the innovator product. So this is the posology. My colleague is passing around our leaflets. It has the dosing regimen, the posology of the product in there. So for say, prevention of VTs after a hip or a knee replacement surgery. So you do 2.5 milligram twice daily. So the whole posology is in the brochure. So why should I switch my patients to Azaban? So the doctor is saying, okay, my patient on Rivaroxaban, it's a direct oral anticoagulant, but they are saying I should switch. Why should I switch? The switch is necessary because Azaban then shows a lower likelihood of bleeding in trials that are stated on the screen. Azaban is also preferred in renally impaired patients. So if your patient has some form of renal impairment, there's the need for him to be on an anticoagulant, oral anticoagulant, then your best choice would be Apixaban, of course, Azaban. This is a comparative analysis of warfarin and other drugs. And as can clearly be seen, Azaban presents with some superior advantage over warfarin and also over other direct oral anticoagulants. So then the switch. How do I do the switch? If I'm switching from warfarin to Azaban, all I have to do is to discontinue the warfarin. Then you monitor the INR of the patient. Once it gets to below 2.0, then you switch to Azaban. So discontinue warfarin, monitor INR. Once it gets to below 2.0, then you switch to Azaban. But if you are switching from Rivaroxaban or any other direct oral anticoagulant, Azaban is quite direct. So if the patient takes his or her DOAC today, the next dose, which is tomorrow, he can switch to Azaban. So from one direct oral anticoagulant to Azaban is quite straightforward. So in summary, we say anticoagulants are key because direct oral anticoagulants are the safest and most convenient. Apixaban has shown in major trials to be the safest, especially in renal impaired patients. So Azaban is safe with low risk of bleeding and also very cost effective. So at then we say when the need for anticoagulation arises, as it often does, go safe, go convenient, go quality, go cost effective. The goal is that you recommend Azaban for your patients. Thank you very much.
Thank you very much. Thank you for your presentation. Now, apologies to Dr. Robert Lampley and the team. Now I call you the team. You may proceed. Thank you.
Yes. Good morning once again. Thank you for giving us the opportunity to present our recent study that we did. It was a feasibility study. And today I'm here with my team, which includes me, Dr. Roberto Lamte, Dr. Abel, who is the trial manager, Dr. Stephen Eggman, Dr. Gloria Nyasamuan, Dr. Pupa Sari, Dr. Naku Apoka, Dr. Anita Tibor, and I think that is all there is. So today, this is going to be our agenda. We're going to go through the introduction, methods, qualitative results, our quantitative results, as well as discussion and conclusion. Now, back to the pre-talks. As soon as I entered, Dr. Aya was like, which football team is this? So I guess I need to tell you about CREATE. So you need to know about us. So CREATE is an NIHR research group in Africa, which is to do collaborative care for cardiometabolic disease in Africa. So the acronym CREATE came from that. And that's the team. Why were we created? So the United Nations goal of ending poverty and for us to enjoy peace and prosperity, develop what we call the Sustainable Development Goals. There are 17 of them. And for us, CREATE, this is why we are here. And we've aligned ourselves to one of the goals, which is the SDG 3. And it talks about what? Good health and well-being. What does it entail? It entails, the 3.4 talks about reducing mortality, premature mortality with NCDs, and to promote mental health care, as well as to achieve universal health care. Together with CREATE, what we do is that we hope to, with our research and our things, be able to inform policymakers, and with that, we'll be able to improve that. Now, another thing about the SDG 3 talks about training. See us here. It's all because of the CREATE training to present our findings. Now, so enough about CREATE. I hope I've been able to tell you who we are. We are not a football team. I don't have any jersey number. So our running title was Collaborative Care for Cardiometabolic Disease in Africa. That was the feasibility studies. Our aim was to generate scientific evidence so that we show that education changes behavior. Which behavior are we talking about? Physical activity, diet, what we eat. That the research that we did was a structured self-management that showed that when you educate people, when you tell them about the truth, they are actually going to change. And our results will show what we talked about. Again, is to improve health outcomes for people in low resource settings based on the evidence we generate, as well as to improve our practice as well. And last but not the least, to inform policy makers. Now, to the background of this study. We know that NCDs is increasing in Sub-Saharan Africa. The WHO with the cardiovascular disease making most of it. And what is happening is that 80% of these deaths are occurring in Sub-Saharan Africa, which Ghana is part of it. So this is a problem. Now let's come to our main country. This was a prevalence study. So for the past 5 years, we realized that the prevalence has been increasing. So you look at a research done by Swanade in 2020, where the prevalence of hypertension was found to be 59%. Again, you go down to Derby, also 54%. Even our own Dr. A.C. Boate, of his research that he did, what he found was that apparent hypertension among people were about 19%. And the interesting is that majority of these people were actually below 64 years. Now, the SDG goal that talks about preventing premature deaths. If these individuals are having resistant hypertension at this age, less than 64 years, then we have a lot of things to do. Again, some research done on chronic kidney disease, diabetes, with the CKD, A.J. et al., what he realized was that people who live in our country were more at risk of getting chronic kidney disease than people who live in Europe. And he got the equivalence of 13%. Again, Sapo et al. To stroke survivors. And that was an interesting study because people who had survived stroke and were coming to their clinics for review, what they realized that about 25% had diabetes. Yes, though their sugars were not controlled. And more interestingly, they found that those that had stroke and had survived, majority of them didn't even know they had diabetes. And the sugars they were recording was actually in ranges of diabetes diagnosis as well as intermediate diabetes. So the question is, what are we doing? And that is what our PCB studies is going to show. There's been several interventions, including NABU in 2019, where she was trying to determine whether social support would affect, there was any association with social support and hypertension. What she found was actually interesting. There was no association, but she found something. She found that cohabiting, even with 2 or more people, was going to increase your chance of BP control. But she found that was more in men than women. The question is why? She also found out that cohabiting actually improves men whose BP, like she found out that men who were cohabiting had good BP control, but the rest there was nothing to show for. So should we encourage cohabiting? That's another question for another day. So Dr. Kwesilamti herself did a structured diabetes self-management education. Even though she found no difference in the HbA1c, she found something. There was a drop as compared to the normal people who were not part of the research, a significant drop. So that means structured self-management education works. And that's why we are here to present our research. Next up, we are going to show you how we did it. That's going to be done by Dr. Stephen Ekman. Thank you.
Okay, so with the methodology, the study design used was a single arm mixed method feasibility trial. So what it meant was that the participants recruited were just an intervention, was only an intervention. There was no comparator or control group. And this study, as has been mentioned, was done at the Kolibu Polyclinic Family Medicine Department and other sites in Kenya and Mozambique. So our population were patients with cardiometabolic diseases, that is type 2 diabetes, hypertension, stroke, and coronary heart disease. So for the quantitative, we selected patients with cardiometabolic disease. Then for the qualitative arm, we interviewed and had focus group discussion with key stakeholders, which include community leaders, healthcare professionals, and those involved in the trial delivery. We use purposive sampling technique, and for the Ghana site, we recruited 53 participants. With the eligibility criteria, the patient had to be 18 years or above, diagnosed with cardiometabolic disease. But then, if the patient was unable to speak English, P, or Ghana, they were excluded. This is because the intervention was delivered in these 3 languages. Then participation, if the patient was participating in another study, or they were unable to be part of the group intervention, education intervention, they were also excluded. So there were several outcomes that were measured at baseline, then after the intervention at 3 months, and then at 6 months. But then our primary outcome here was the change in quality of life score, the change in glycemic control, the change in BP control, and then the lipid control. Dr. Glorinia, some of the quote.
So we are looking at the pre-test. So for the pre-test, we carried out the pre-test in April 2023 at the Mamubi Hospital, which shares similar characteristics as Kolibu Polyclinic Family Medicine Department. And it was to test tools for the intervention and also to help us time our data collection period and then schedule our patients appropriately during the intervention. During the interim, from the 28th to the 29th of July 2023, we had a training of educators, and educators cut across pharmacists, doctors, nurses, and the idea was that in the CREATE delivery, we don't identify yourself by your cadre, but you are an educator, you are a collaborator. You don't impose your qualifications. So during that training, we went through the curriculum, and the curriculum was adapted to suit the Ghanaian society, and therefore it was also transcribed or translated into Chi and Ga as well. And the training sought to bring out the principles of CREATE, which was to set up a collaborative learning process for patients to acquire self-efficacy in their management, because basically managing chronic diseases is not about you, the provider. The patient or participant in question should be in control. And so, following the training of educators, we had baseline data collection, which was done in September 2023. Now, during the baseline data collection, anthropometric data such as their waist circumference, their weight, their blood pressure was collected, in addition to blood samples for HbA1c, lipid, and also urine samples for urine alcohol creatinine ratio. Following the baseline data collection, we had the intervention period where we saw the 53 participants through 2 sessions in, we had 3 groups, all coming in 2 sessions per group. And these interventions were carried out under the various languages, English, Twi, and Ga. And basically, patients were taken through that. And as you can see from the picture, we had a theme for it. The idea is that every group will be united towards the cause of improving their cardiometabolic factors. So for English, and these are handbooks. So we had Biakuye, in Chi. So that was the theme. The guys used Ekubefebo, Lumni, Nihiwalayo. Then in Unity, Life Strength, that was the English one. Then, so from baseline, we took a 3-month data collection again, where their samples were taken, their metric measurements were done. And that was done. And then the 6 months follow-up was done again in February 2024. And these were also an opportunity for us to collect the same baseline, the same data or anthropometric as well as blood and urine samples for comparison. These are the handbooks that we used, and these were given to the patient so that they could go and take charge of their self-management. The last slide shows us making our training intervention materials, and these were materials that were indigenized. So patients could identify, if you're talking about food, they could see fufu, they could see kelewele and all that. And all these were put together. They went through trainings on physical activity, discussions on diet, and then even self-management. So they came up with their own management plan at the end of it. Thank you.
Thank you. So I'll take the next presentation. So as already been said, we have some educational material for our clients, and to be able to educate people, the people must appreciate the material that you provide. And so even though the materials had been brought to us by the great team, we also needed to go through and make sure that it was culturally suitable for our Ghanaian population. And so we needed to bring up a team of people whom we call the community engagement panel to sit together to see whether the documents or the educational materials were going to make sense to our population. And so we had to get a large group of people, including medical doctors. So we had people from the endocrine society, we had palliative care doctors, we had herbal medicine practitioners, then we had public health nurses. We also had fitness instructors. We have people from religious organizations, there were pastors with us. And then most importantly, there were the patients themselves and their caregivers. After all, the documents were going to be used for them, and so they needed to appreciate the content. We had to sit together for 3 sessions over a period of 3 months. So at every meeting, we brought the documents that had come, we project them, and then they will look at it, and then they will make comments about the documents that we had. So the issue is that most of the educational material came in with clip art images, and our patients were not amused at all. Most of them said, so these are some of the pictures I took. So you see somebody sweeping, somebody standing by the sink, and they asked us, what does that look like? They don't understand that image, we should change it. So they wanted us to use real life images. So we had to go for people now to act the images out and all most of the symptoms and signs of diabetes, hypertension that we wanted to show. The food, we had to get local food, prepare local dishes. We took images of it. People said the yam in the picture did not look like yam, it looked like something else. They said egg looked like pancake, and they didn't think that we should show egg as pancake. It was a difficult period, but it was a successful one. At the end of the day, we were all happy with the images that we came up with. So we have our pastors who helped us through the preparation of the document. And this is our doctor from the Center for Plant and Medicine Research. It was also a very important part in the preparation of our document. And so, as I said, after we had done the educational material, which was the structured educational material for our patients with diabetes, Create's main purpose is that will improve the outcome of care for our clients with cardiometabolic diseases. And so we cannot sit in our health facilities and say that we'll deliver structured educational materials and improve cardiometabolic disease. But most of our clients are in the community. They are not with us in the hospital. So we needed to go out into the community to also involve them. How would we get to them in the community? We can't do it as doctors. We are already overwhelmed in our consulting room. So we needed to make partners. So we said we will look for community partners. Who were going to be these community partners? So we thought that, well, we have community pharmacists, patients, people, we all go to the community pharmacists. So they were a good point to start from. We looked at local groups. So there are some communities where they have local groups that do education in maybe substance abuse, sexual life and all that. We tried to go into the community to find some of these groups, and we found a couple of them. Then we also had fitness groups. A lot of people now join fit clubs and all that. And fitness is a part of managing cardiometabolic disease. So we tried to find a fitness club, and then churches, mosques. Everybody belongs to a church or a mosque. So we said, let's get brothers from the mosque, our brothers from the churches also involved. So we sent our letters to some of these churches and mosques and organizations, and we invited them. They were happy that they came over, even though they knew that they were not going to get anything for the work we were going to do. They were willing to help us in the fight against cardiometabolic disease. So this is one of the community groups for our Shipe. This is also our community pharmacists right opposite Kolebu, and they are doing. So that is what happened. They came in for the education. We provided them with manuals, posters, and gave them logbooks to go out into the community to have conversations with their people. This is our Keep group. Over 150 members of that Keep group. They were really helpful. So we brought all these people together. We gave them the training, and then we took them back into the community to have these conversations with their people. Took the opportunity to go out and visit them and to see how these trainings work. We helped them in their challenges, and I would say at the end of the day, done a very good job. Thank you very much.
A very quick one. Car number BR 8648 22, the Land Cruiser, causing obstruction to outflow from the hotel. Can you please go down and assist? Thank you.
Good morning once again. My name is Abusi Kovansari. So I'll take you through the recruitment process very briefly. Our study site, as has been mentioned, was the Liverpool Polyclinic Family Medicine Department. So what we did was we purposely sampled 66 patients who had known cardiometabolic diseases, and we had telephone. We called them over the telephone, and then we booked them for particular dates and then to come. And finally, we recruited 53 of the patients. And the reasons why we excluded some of them were because although we saw in their history that they had cardiometabolic disease, when they came to see us, that was the case. And then also because some of them didn't turn up, and also because at the time by day 3 we were done, we had gotten the numbers because our aim was to get 52 people. So about day 3 we had gotten the numbers. So then the other people couldn't include them in the study. And then one of them had type 1 diabetes, that's an exclusion criteria. And one of them refused to sign the consent. So we excluded that patient. Thank you very much.
So I'll be presenting the results of our study. So after we implemented the intervention, what difference didn't make after the 6 months follow-up. So in all, we had 53 participants, and we had 31 of them being females, 20 of them being females. The mean age of all the participants was 59 years. So in terms of family history, 26 of them, 49% of them had at least type 2 diabetes, and then 86% of them had at least hypertension. We had females having, most of them who had hypertension and diabetes were females. And we had one patient having stroke. In terms of family history, 28% of them had a family history of stroke. 8% of them, 16% of them had a family history of stroke before the age of 65. 82% of them had a family history of hypertension. We had 22% of them having a family history of high cholesterol. So what changes occurred from baseline to 3 months? So we realized that there was a significant change in their weight. So between baseline and 3 months, their weight fell by 2 kilograms. And then waist circumference also fell by 3 centimeters, and this was significant. In terms of the glucose, we had the mean random blood glucose falling by 0.05. This was not significant. However, for plasma glucose, it fell by 1 millimole, and this was significant. So for mean cholesterol, between baseline and 3 months, we saw a drop in the total cholesterol by 0.5 millimoles. And HDL cholesterol also fell by 0.3 millimoles. Triglyceride also fell by 0.5 millimoles, and then the LDL also fell by 0.2 millimoles. And these were all significant. We saw a drop in both sodium and then potassium. However, we didn't measure the urine sodium, so we can't tell the reason why the sodium fell by that much. So from baseline to 6 months, these are the results. Systolic blood pressure fell by 5 millimeters of mercury, and then diastolic blood pressure fell by 3 millimeters of mercury, and these were all significant. Weight circumference was still fell by 3 centimeters, and then the weight also went down by 2 kilograms. We had an increase in the HbA1c from baseline to 6 months. However, we couldn't tell what exactly were the reasons to this increase in HbA1c. So at the end of the day, at the end of 6 months, we saw a reduction in the random blood glucose by 1 millimole, increase in the HbA1c, reduction in the HDL cholesterol, reduction in triglyceride, and reduction in sodium and potassium. There was no change in depression scores or well-being scores throughout the period of the study. So in terms of, we did a regression analysis of certain parameters that we took in the study. So for our dependent variables, we have the HbA1c, serum creatinine, urine output creatinine ratio, the systolic blood pressure, the weight, and waist circumference to height ratio, and then also self-efficacy. And these are our independent variables. So when we run the Pearman's correlation, we realized that there was a significant association between there was a significant association between the mean systolic blood pressure and also the diastolic blood pressure, and also found that there was a significant association with the blood glucose and then the HbA1c. So when we ran the mixed effects model, we saw that over time, the HbA1c increased, and this was significant. We also realized that if someone had a history of type 2 diabetes, the LDL cholesterol, there was a significant association between having type 2 diabetes and then LDL cholesterol. And the LDL cholesterol fell over time. And also we realized that over the period of the study, between baseline, systolic blood pressure fell with time. And also the same applied to the weight. There was a decrease in weight over the period of time. Same also applies to weight circumference, as mentioned earlier. In terms of self-efficacy, we realized that over time, the self-efficacy scores increased, but this was not significant. So I'll call on Dr. Darko to continue with the result of the qualitative study.
So I'm going to talk about the qualitative arm of the study and what we found. So we interviewed different groups. We looked at our participants. We looked at our staff, the trial staff. We looked at educators, our community champions, that's what the pioneers are, as well as the stakeholders of the CREATE team. We had both individual interviews, informal interviews, focus group discussions. So, what was the consensus on cardiometabolic disease? Those of us in Accra, I know that the sun has been blazing. The temperatures are increasing and it's a burden, and that is what people agreed on with cardiometabolic disease, that it's increasing and it's a burden. We had a participant tell us that, a healthcare practitioner tell us that it's a burden. It's really a burden, a big burden. That's what I can say, because it's not a little burden. One other healthcare practitioner told us that 3 or 4 in every 10 people that you may encounter at your OPD would have a combination of these diseases. So it's something that we are seeing very frequently. That was the experience of the healthcare practitioner. So we asked about the CREATE intervention. We looked at the delivery, we looked at the handbook, we looked at the venue, we looked at the food that was served, we looked at the time, the duration with which we had the intervention. So for the delivery, the handbook, and the venue, it was positive reviews on all counts. Everybody agreed that those were very useful and very helpful. One participant said the value is enormous, especially in my community and my house, meaning that he took it home, he took it to his surroundings to use. Another was the handbook has been very, and he stressed, very useful. And I use it as a reference book or encyclopedia. So they didn't just come and throw the book somewhere like sometimes we do, but they put it to use. The venue was superb. Yes, we had it in a very comfortable place, and air conditioned, the washroom, they were very. So with the duration and the food, that was where we didn't have a consensus. We were split down the middle. So for some, the 2 days was very good. Being able to finish the whole document within 2 days was good. For others, it was a lot to learn, a lot to unpack within 2 days. The time was too short and it was intensive. So they felt a bit overwhelmed. That was what was communicated. Now with the food, in my picture, you can see African star fruit. It's something that grows apparently very well here in Ghana, but I don't think if I ask anyone, any of us to show by hand how many of us eat star fruit regular, any of us would lift our hand. So this came from our healthcare practitioners. Our healthcare practitioners actually had quite a lot of negative reviews. So the food didn't go well. I only managed to eat, but most of our people threw the food away. The food we served were low carb, low sodium. So we had bananas instead of plantain. We had contomere without oil, without salt. It was spiced. Yeah, I hear. So that was the reaction. And we are healthcare workers here too, so I'm sure we would have had the same reaction. The participants, however, the theme, yes, they weren't used to it. They didn't take all of it lightly, but they were more willing to try. And as for the food, I was happy because that is what they are trying to proclaim. That's what we are trying to do. So show your way, If you are saying that we should eat well, the food served should be good. So those were some of the experiences. With implementation, our enablers and barriers, you can see my figure, it's money and time. It can't happen without money and the time. So for sustainability, I think the policymakers should come into the picture seriously. If the financial aspect is not there, it might affect the great intervention. No money, no intervention. And the whole healthcare culture is a barrier to implementing it. That's what one of our educators put forth. Now, in our OPDs, how much time do we have to really talk to our patients? How much time do we have to let them really, to make sure that they've understood the food that we eat, on a daily basis? How do we do that? Are we practicing what we preach as healthcare practitioners? So, as Nkrumah said, we look forward. So we are hoping to move forward. Every client with any of these cardiometabolic disorders deserves to be a part of it. It's being the creative intervention. We should talk to the higher powers and the stakeholders to incorporate it into the national so that we roll it out as a big project. So most people are talking about upscaling and moving it forward. So we hope to do that. Thank you very much. We now go on to our discussion.
Good morning, once again. Anita, and I'll be going the discussion and then also start the limitation. So generally, the quantitative study, the quantitative results that showed improvement in all the variables. So the biomarkers, except for HbA1c, all the biomarkers showed improvements. There were also improvements in the anthropometric measures, so with circumference and weight. And these improvements occurred at 3 months, were also sustained at 6 months. And when you put those quantitative values together with the qualitative results, so the general experience and perspectives of the participants, we can make a general statement that when patients are put in of the decisions they make regarding diet, regarding their physical activity, regarding their health, and when they are educated on the theories and the practicalities. So it wasn't just about telling them what to do. We explained to them why they had to do, and it was a collaborative thing. It wasn't about us teaching them. We got their experiences, we got their perspectives, and they use those things to bring their minds to certain aspects of their health care. When we did that, we saw improvement in some of their health markers. And so it means that if we implement structured self-management programs, we are going to see improvements in the health of our patients. So the qualitative also highlighted certain issues in our healthcare system. Dr. Dalton already spoke about some of them, but those issues will probably be the ones that are going to take us down when it comes to implementing structured self-management education. So first space, you mentioned that the venue was fine. At the polyclinic, I'm sure it's replicated in different hospitals. At the polyclinic, for example, some of consulting rooms are shared. So you have two doctors in the consulting room. Sometimes you'll be talking to one patient and you can clearly see that the other patient at the other table is listening into what you are saying. Sometimes you even chip in and give their experience. And so we need space. We need space to be able to engage our patients one-on-one, to give them the education, to show them. When we're doing the preparation, you saw the stats of pictures. We took pictures of the local foods. So you saw those stats. We are going to replicate that in our consultants. You can't be sharing that space and be doing that. The other patient is going to be interested in what you are doing. Why are you showing pictures? Why are you showing samples of? So we need that space. And then also the time. The intervention itself took so much time. So some of the patients that was intensive because we had to pack so much into 2 days. And some of the chapters, so for example, the chapter on food, if we decided to talk about the food, that topic alone would have taken 2 days. So we had to pack it into 1 hour. And there were so many questions. If we do this, what should I do? What should I eat? How should I eat? Can you show us how to prepare the food? And so if we are going to implement this, we are going to need so much time to actually take our clients through the self-structured education. Then money, the PA study was fully funded. We earlier spoke about collaborative research, and we know a lot of times one of the limitations is funding. The PA study was fully funded by the NIH. If we were to replicate this, where are we going to get that money from? Who is going to fund the materials that we are going to use? And our OPDs is sustained if doctors were seeing 5 patients in a day, because if you go to work for 6 hours, 2 to 8, and you are seeing 1 patient and you are doing self-structured management education, and you are using 1 hour for 1 patient, it means that you're going to see 5 or 6 patients at your shift. And our OPDs is sustained if we do that. Then also culture. So there were issues of the cultural implications of faith. One of our participants actually almost had a nervous breakdown because she was receiving abuse. She lost so much weight. She was receiving abuse from her family members because we were asking her if she's sick. And we all know that this is very common. Some of us, Dr. Lawson said if you are told that you are looking nice, it means you have been. That is the only explanation, because if you were losing weight, you will be asked, are you sick? And so the culture, being healthy and looking healthy, have different meanings. You might not be healthy, you are obese, but you are being told you are looking fine. And so those cultural implications also have a lot to do with our delivery and implementation of self-structured management education. So the limitations, we mentioned that we did purposive sampling of the participants. And so these participants were selected. This was a feasibility study. So there was no randomization, we had just 1 arm. And so you cannot really generalize the results. You can say that, okay, there is something there, so let's go deeply into that. Also, participant motivation. So we introduced ourselves as educators. But then we mentioned that the site of the study was the Kolebu Teaching Hospital. And a lot of us came from the Kolebu Teaching Hospital for the family medicine department. And so the clients knew us as their doctors, as their pharmacists, as their nurses. And they knew that 3 months' time we'll be taking samples, 6 months' time we'll be taking samples. So could it be that because they knew that we'll be taking their samples, they were determined that they are going to pass the exam? And so whatever they will do to pass the exam, will pass it. And after that, it's true for passing. So is it that motivation was there, or it was actually the effect of the self-structured management education? So this was the feasibility study. So we cannot really make generalized statements. And so what we want to do, move on to a randomized control trial. And that is where we can actually come out and say that yes, we need to involve policy so that we have self-structured management education as part of our healthcare policy. And so we can see builders fixing the roof. Our roof needs fixing. The policy has to change. And so this is what the study sought to do, to find a reason so that we can implement self-structured management education as part of our healthcare system. So in conclusion, we need a larger trial that can confirm that indeed self-structured management education works. Thank you very much.
Thank you very much. And I hope the great team has done a good SWOT analysis for the judge. Well, peace. So we are done. Thank you very much.
Thank you very much. I've changed my idea about the high school babies and the rest. And even Prof, we'll consider them for fellowship. Of course, fellowship is not only cardiometabolic. Yeah, we've sat down for a long time. Can we just stand and march at the same spot? 10 steps. Let's do it quickly. All right, left, right, left, right, left, right, left, right, left, right, left, right, two more, left, right, left, right. We are done. Have a seat. As for a snack, just carry for a while. In fact, Prof, you have to educate Dr. Lamptey, you have to educate them about glycogen genolysis and then gluconeogenesis. We should be able to survive. Good. So, question time. Now, I gave them more time because we're doing very well. But I can see President coming. A political statement. Okay. Now, so I've been prompted that we have Boehringer Ingelheim. Boehringer, this is a drug firm. They have been around for as long as some of us here have been in the world. So, 5 minutes, do your presentation.
Great. So, pleasant good morning to support. My name is Jonah Asante. I'm key account manager for Boehringer Ingelheim. We are happy to support this year's annual or AGSM. I think we've been doing this for a while now, and it's been a very fruitful collaboration. So this morning I'll be speaking on a topic you're all very familiar with, but just to highlight some new concepts, and I think some of which has already been highlighted in the CREATE program. I think it's a very fascinating study. So we are looking at the use of the SGLT in the management of type 2 diabetes, but also the extended use, particularly relating to cardiovascular diseases, particularly heart failure, as well as renal diseases. And all these have been proven by evidence as rolled out by Boehringer Ingelheim. But then the emphasis has to do with its use in a more different approach, right? So we're looking at the relevance in early use rather than later use. And again, use of the product in broad indications, and then as a foundational therapy. And here we mean using it in a way that it's considered one of the cornerstone therapies for NTEs relating to diabetes. Great, so the product is Jardiance. The name is, proprietary name is empagliflozin. It comes in 2 strengths. You have the 10 milligram and then the 25 milligram. Please, if you don't have it in your facilities, my rep in office at the back, we will see how best we can collaborate with you to make it available in the facility, because that's one of the approaches we are looking at. The retail trade is really not helping. There are so many markups that makes it even more pricey to get these products to the patients. But we'll start with a case study. So let's meet Ifia. She's from the Eastern region, 50 years of age. She was diagnosed with type 2 diabetes 5 years ago by a family physician, any of them in the region. But then recently has been diagnosed with coronary artery disease
And then we are beginning to see more and more complications, including renal complications. So family history, like we come to know, is important. She has a strong family history because mother had type 2 diabetes and died of a stroke. Lifestyle, she's trying to do the best, taking a lot of the counseling that has been given by her doctors. And then she doesn't smoke, which is a good thing, but drinks occasionally. I'll skip the vital, but just to highlight the drug history. So these are the regular medicines you find in our district hospitals, based on what's available at the regional medical stores, what's available around. And again, these are medicines we tend to use a lot. They are good, but then the point is there room for change, right? Can we do better in terms of getting outcomes and based on data? So what we have done for years, including what we may still be doing, is the fact that we seem to highlight intensive glycemic control in our patients, which is important. But if you look at a lot of the meta-analysis, we find out that the impact of these intensive glycemic control on major cardiovascular disease tend to be a little modest, all right? Which means that there's still a lot of gaps and we need to do more. In fact, the impact on all-cause mortality is of no effect, even though we are doing the best we can, but reducing the HbA1c, dealing with the fasting blood sugars, all right? Question is, can we do more? So there's been a paradigm shift, and this has happened since the 2020s, or maybe a bit earlier than that. Here we are trying to not only focus on the HbA1c, but look at the multifactorial interventions, right? So we are looking at what more we can do for the patients, as well as those events that lead to death. So are the medicines going to impact cardiovascular death? Are they going to impact renal outcomes, etc.? And that's the approach we are seeking to do. Now, why is this necessary? And based on the previous discussions, we've come to appreciate the interconnectedness of the cardio-renal metabolic system. And these manifest in three ways. That these conditions tend to coexist, which is something we should not forget as upcoming conditions. Being the point of call, patient is type 2 diabetic, all well and good, but let's not forget many times there's subtle conditions of heart disease somewhere in the background. And sometimes in other patients will manifest as renal conditions. So they tend to coexist. Then they tend to amplify each other. So they kind of hype each other up, and then they tend to be progressive. So anytime you see that a patient has had a problem with their heart, many times there are related problems from type 2 diabetes and other systemic conditions, which is from the liver, insulin control, pancreas, etc. And then sooner or later, we start having problems with the filter. Hence, the need for us to be a bit more aggressive with our diabetic patients, which a lot. I mean, we're having a roundtable yesterday with clinicians from the Eastern Regional Hospital, and they tell us the numbers, the sheer number of type 2 diabetes that they are managing on a regular basis. Now, the heart failure burden is a problem. We all know the connection between type 2 diabetes. I'm sure we are familiar with these slides, but EMPA has been approved for use in heart failure, not only in reduced ejection fraction, but also in preserved ejection fraction. So it's been considered as part of the big four, or the big three, put it that way, the ANIs, beta blockers, MRAs, and now the SGLT2s. And our preference would be anti-influxing for the patients. Then we talk about the pump, we talk about the filter. Without the pump, there's no filter. So that interconnectedness is what I'm trying to highlight in these slides. Many times, let's not forget the pipe that is flowing is from type 2 diabetes. These are the patients you're seeing more. Though they may not have complications at the start or when you're seeing them, we need to treat them as though they have the condition already. And yesterday I was just illustrating this. Because many times on average study, it's the process of acceptance of type 2 diabetes. It takes a while. There's now for a number of months, sometimes years. Then they will do herbal medicine and so many other things. But then you notice that once it gets to places like this, then there's a need for us to really, do what would be best for them. So Again, other guidelines are highlighting the use of SGLT in addition to lifestyle modification. I'll skip this slide, but just sought to highlight the impact of any intervention. So we just sought to highlight that patients on empagliflozin had additional life or additional years to kidney replacements once they were initiated on empagliflozin, with the based on the benefits compared to when they were not initiated on empagliflozin. So it all starts with type 2 diabetes, like we've come to know. The guidelines are saying that SGLT2s have a role to play. Indeed, in this algorithm was considered sort of second line, but current algorithm suggests that it's continuing to use as first line. Once the patients can afford, which is important, and again, in combination with metformin, which will always be prepared. I'll skip this slide, but again, just to tell you the sort of work that VIA has done to make these products available. And globally, we are the leading SGLT2. Here in Ghana, we are a relatively smaller country, but we believe that there is room for us to collaborate with, big platforms like Topcock, move the brand forward. The benefits are well known. Dr. Robert Alamte has been a champion of these brands based on his ability to reduce the HbA1c, systolic blood pressure, and also the weight of the patients. The starting dose typically will be 10 milligrams. You may want to increase it to 25 milligrams if you want tighter glycemic control, and then it can be taken with or without food any time of day. It can be combined with your earlier medications, be it Socola, UBS, or with insulin, but you need to always be mindful of the rates of hypoglycemia. So you have the 10 milligram that has other indications in heart failure. And for us, it's really exciting to see the impact that is having on heart failure. And in some of the testimonies are really refreshing to hear. Then you have the 25 milligram, particularly for the endocrinologists and the family physicians. Because again, I'm saying that type 2 diabetes is where we win big. By the time you get to the complications, the patients are spending so much money, there's too much frustration, there's minimal impact. So we must win with Jardiance when it comes to type 2 diabetes. Then we're talking about the use of Synjardy, or we are introducing Synjardy, which is Jardiance or empagliflozin plus metformin. It comes in 4 SKUs, so there's that flexibility of what you want to choose. Typically, you're doing a BD dose, so morning, evening, so you have 5,000, which is most likely what you will most prescribe, but we also have the higher strength for your patients. Currently, most of these brands are available in the retail space, but I strongly believe that we can win bigger and get excellent pricing when we get to the cost. We cut away the markups, we cut away all the challenges with access, and makes it even more better for our patients. So thank you very much, and I'm grateful for your time. Thank you so much for watching.
Thank you very much. Yes. So let me introduce the. Now we have time for sessions, questions, contributions. Of course, and I'll remind you the slides will be made available, and also the doc verbs will be outside, so you can go and ask questions over there. We have 5 minutes for the questions, so let's be as brief as possible.
Thank you. My question goes to the drug. He is smiling because he knows what I'm going to talk about. So you painted a beautiful picture about your drug, but you haven't told us anything about the side effects. And the major side effect is the price. Major. Everybody is complaining about the price. So please, let me finish. If you want us to promote your drugs, you have to do something for us. You've got to reduce them drastically. Because you might be talking about Kumasi, but I tell you, those of us who practice out Kumasi, you are 90% of the people who prescribe these medicines for can't afford it. They will be prepared to buy a coffin and keep it throughout when they die. They are buried with it. Please bring it up. It's too expensive. Thank you.
contributions? Zero. Okay.
Yes, so please, I'd like to ask a question. I'd like to say that regarding the side effects, indeed, I mean, all medicines come with side effects. I'm sure you're familiar with the mechanism that because of glucose. There's a lot of glucose that is passing out through urine. So there's always a risk of UTIs and genital infections. This is a real possibility. What we recommend is that we encourage our patients to do personal hygiene and also to be more hydrated. Indeed, particularly in type 2 diabetes patients, the hydration even helps the molecule deliver better outcomes. Now, with regards to the price, again, that's why I showed the number of studies we are doing. It takes $1 billion to bring products like these to the markets globally, not only in the Ghanaian context. And sometimes you're not even sure if the product will work, So it's a lot of work that pushes the boundary of medical practice. If innovator companies don't do this, we won't have new molecules. I've had the opportunity to work and see some of the effort that goes into it. But that's not to say that we can't do anything about the price. I mean, we need to start from somewhere. So that the consensus is what we are calling for first. But what BI will do is they would want to find out if our doctors are even aware of the product. If they are not aware, there's no need to deliver on a price reduction. Then are patients engaging with the molecule? Have they found the benefit? Are they willing to continue using it? Then it gives us a sustainable, matrix for us to go to do a price reduction. I mean, I was discussing with, again, my team. It's very possible to reduce the price to the barest minimum. This is a company-owned business. And in scenarios in places like South Africa, they are able to have the price. We just need to do the business case. So what we'll say is, let's get the acceptance of the products by softball. If the Florida District Hospital, I don't know if there's any such, but if they're able to do 1,000 packs, we'll drop the prices. And then again, that's why I'm calling for the prices and the products to be available in the hospitals. I think this would work. It's gradual. Then there are also other plans to get it into the Ministry of Health, into the NHIS. But again, all that will take time. And they also want to be sure that we have done the problem.
Thank you. Thank you. Dr. Roberta Lampe is still here. Dr. Isi Watson is still here. 2 minutes. Any more questions before I start doing the countdown for the bio break?
Right.
Thank you very much again. I want to say congratulations to those who did the presentation. I am not going to do a lot of words, but I still have to do it. From my background of an epidemiologist, public physician, public health physician, and some other things, normally doing such a survey without a control arm is a little bit suspect. And it is very difficult to get the funding for such a research. So, but you have promised us that you are going to do further studies, because you can't convince me, honestly, to do 6-month research without the controller. That's all I want to say. Thank you very much.
Thank you. Any other comments?
Yes, please.
Yes.
The HbA1c increased by 1%. I don't know if I heard you comment about it, but if it started, golden started for us to see the control, then how are we going to consider this as bad intervention? That's my first question comment. The second one, the implementation of this idea I think it is already done elsewhere. I believe it's already done elsewhere to educate and empower our clients' patients. And it is done not by the doctors, but by other members. So we have nurses, we have community health workers. So why I don't agree that we should do a trial. I think it's a very good idea, but we should get other team members to be on board and just go run with it. Thank you.
Thank you very much. Okay, so the last one.
Yes.
Okay.
So to address Dr. Spangenberg's comments, so thank you very much for the question. The education we receive, as you described it, it's not structured. It's not structured. The nurses and dietitians who give such education, they are not educated with a self-management curriculum. So that is what we are trying to see. That's why you use a structured system. It means that they are going to get the same education, whether it's a dietitian who gives it, whether it's a nurse who gives it, whether it's a doctor who gives it. Because we are educated according to the curriculum and we give the same exact information to the patients. Of course, that is directed towards their patient context. And that is what we are saying. The education given currently is not structured, but the CREATE team wants to bring it to policy, a self-structured management education. Thank you.
Thank you. Okay. Oh, you want to emphasize something?
Just to.
A minute.
Yes. So, thank you for the question. I'm addressing the first question as with respect to the feasibility and whether we should go according to it. So, like we mentioned in our presentation, it's a feasibility study. So we want to see whether it's possible to carry out a bigger study, which is the randomized control trial in this setting. So that's why we conducted the feasibility study. And then the other thing too is, we mentioned that we have to be mindful of the results because we intentionally picked the participants of the study. So they were purposefully sampled. And that is why we actually, that's why we actually, and we had a very small number, there were 53. But we can't draw conclusions from such a small number. But the main idea here is that it's a feasibility study, and we want to see if it's going to be possible to conduct a much bigger study with a control group in this setting. Thank you.
Okay. So the plaintiffs and the defendants have had their time. Okay. Okay. Right. So we are an hour behind time. Of course, learning something, talking about, discussing issues about strengthening primary care, and especially with the objective of improving and making it possible to achieve the universal health system, which is the theme of our 10th-year AGSM. It's worth spending time. Now, we are taking 10 minutes off. Snacks. So we are going out for snacks. 10 minutes, and we are back. Thank you very much for your forbearance. Thank you. Excuse me, I have been alerted that there are no snacks for the break. We'll rather have lunch later. So 10 minutes, just do some walking and come back for us to. The afternoon is also packed. Thank you.
Maybe I will forget you.
That's my food.
Okay, cool. Yeah, mommy. Papa. Oh, okay. Tell me over. Oh, oh, okay. Okay. Me like this, like when I break the over. Fine, fine. Now, the same is where you find it from? They think this is the same as the same. You go to from the fun, but they invite them. Some of them. It's a the relating point, not go where go see the bridge.
Please, can we start coming in to continue the session? Please, can we come in to start with the next session?
Hello, hello. Yes, please kindly sit down. Whilst we are still congregating, we'll give AstraZeneca a chance to do just a 5 minutes presentation. Five minutes for AstraZeneca. Thank you.
Thank you. Good afternoon. My name is Julia Wellen Spencer. I'm with AstraZeneca. I work with them as their medical science liaison, and thank you so much for welcoming us to your program. I would say that I think SGLT2s are having a moment in terms of in the world space in terms of CBRM. I with AstraZeneca, we don't only work with SGLT2s, but we do more work in terms of sustainability. We're committed to improving the lives of millions around the world, be it health, the society, as well as the planet also. But a lot of our work is in CBRM, seen as is the #1 cause of death worldwide in type 2 DM, heart failure, CKD, as well as NASH. So we're committed to continuous education, research and development, and leading in science in the CBRM space. And in fact, our ambition is to be the leading CBRM company by 2030. So we have a lot of work in type 2 DM, like I mentioned, CKD, cardiovascular disease, as well as heart failure. And it's basically our work in heart failure that I want to highlight today, and seeing us as a growing public health concern with very high mortality and morbidity. It's estimated that 64 million people worldwide suffer from heart failure, and it comes with a great cost in terms of health burden as well as economic burden. In over 65 years old is the leading cause of hospitalization, and it's estimated that by 5 years, a person who has been diagnosed with heart failure will be 50% of the people diagnosed with heart failure will have died. Okay, so now despite all this growing mortality and morbidity burden, there's actually low rate of
diagnosis or early identification. And lots of patients are not fully implemented on the guideline-directed management therapies as prescribed by some of our international and local guidelines as well. In fact, for a patient who has heart failure, they'll carry their symptoms for about 4 years before about 40% of them are actually diagnosed. So these patients live suffering from all these symptoms of having to move around and being breathless and all that, and not having the diagnosis. Some of them may be even diagnosed with cardiac asthma at some point before they actually have their proper diagnosis. So the only difficulty is that for them, if they're not properly or identified early, every month that therapy is deferred, you confer about an absolute risk of 1% on the patient. So the patient has an increased risk month on month, every month that the patient's therapy is deferred. And this, I think, obviously worsens their morbidity and mortality. So when it comes to heart failure, honestly, in the last, I would say 10 years, there have been great strides in management therapies for improving lifespan. So it started off with the paradigm HF that looked at sacubitril valsartan, and then moved on to DAPA-HF, which looked at dapagliflozin in heart failure with reduced ejection fraction. Emperor Reduced came along as well in 2020, and after 2020, we've seen advances in heart failure with preserved ejection fraction. And that would, we see that the evidence from all the studies we did in reduced ejection fraction led the ESC basically to add on SGLT2s, including dapagliflozin, as one of the foundational therapies for managing heart failure with reduced ejection fraction. So you have the beta blockade, ANDs or RAS blockade, add on SGLT2s and MRAs as so this, on the back of the evidence that was shown in DAPA-HF and some of the other SGLT2 studies, informed this decision to add them on as the foundational therapies for heart failure. But beyond the heart failure with reduced ejection fraction, we do have heart failure with preserved ejection fraction, which is basically the other side of the coin to heart failure. I know that for us here, we see a lot of reduced ejection fraction, but of course, with advances in diagnosis, then the heart failure with preserved ejection fraction therefore increases. So here we're looking at the liver study, which basically looked at dapagliflozin in patients with preserved ejection fraction with or without type 2 diabetes. So we randomized over 6,000 patients with ejection fraction above 40%, with some structural heart disease or some structural abnormality and raised NT-proBNP, and looking at the composite of cardiovascular death and Western heart failure. The interesting thing about this trial is that a majority of the patients, actually 55%, were non-type 2 diabetic. So we know dapagliflozin as a type 2 diabetic medication in the beginning, but now that the benefits have been seen in heart failure with a reduced ejection fraction and even CKD, now we're bringing on its benefits in heart failure with preserved ejection fraction. So another good thing to note is that when it came to the there's some understudied populations in this trial, patients that have been discharged with study, as well as patients who have prior heart failure with reduced ejection fraction, what we call the improved ejection fraction. So it's also interesting to know that the patients were on background standard of care therapy. So if you are in the placebo arm, I mean, you're not just left without anything. You are actually on the therapies that are prescribed for heart failure with preserved ejection fraction. And this would include diuretics, ACE inhibitors, acid, or beta blockers based on your symptoms as well. So when it came to the primary endpoint, you realized that there was an 80% reduction in the relative risk of experiencing the primary endpoint, which was death or worsening heart failure, with a number needed to treat of 32. So if you look at a lot of trials, number needed to treat of 32 is a really good outcome. So it means that you probably treat 32 patients before you can get the protect one patient from the primary outcome. That's needed or worsening heart failure. And that was statistically significant. So on top of that, that trial, that's the DELIVER trial, put the results of the DAPA-HF, which was in reduced ejection fraction, and added on the results for the heart failure with preserved ejection fraction, as well as mid-range ejection fraction, together into a pooled analysis. And this time we're talking about over 11,000 patients, looking at heart failure across the entire spectrum of
ejection fraction. And what we found was that we're looking at the primary endpoint of death, cardiovascular death. So for HFpEF, we know that we have therapies that have been shown to reduce cardiovascular death, RAS blockade, beta blockades, and all that. But when it comes to HFpEF, there haven't been a lot of therapies that are actually demonstrate that they're able to protect the patient in terms of their mobility outcomes. So we look at the mobility outcome, which is CV death, across the entire spectrum, using dapagliflozin against placebo. And what we found is that there's a 14% reduction in the relative risk of experiencing CV death when the patient was on dapagliflozin on top of standard of care, and that was statistically significant. So we also noticed that when we're using other therapies for heart failure, we know that as the ejection fraction rises, some of the benefits of the heart failure drugs are kind of attenuated. So at lower ejection fraction, it looks like they have benefits. But as the ejection fraction goes higher, it sometimes looks like it's not as beneficial. But when you look at dapagliflozin in the pooled analysis, we realize that across the entire ejection fraction, be it below 40 or not, the benefits were consistently below the line of showing that it was statistically significant, or the results were significant irrespective of the ejection fraction. And when we look at other therapies like ARBs, ANIs, MRAs, or digitalis, you realize that as the ejection fraction increases, then some of the benefits that you see in terms of CV death and hospitalization for heart failure is reduced. And you can see here that the hazard ratio tends to move above the line of limit. Okay, so it's with this evidence that the ESC and AHA and some of the international bodies have basically updated their guidelines. Last year, they did a full first update on their guidelines, looking at the evidence that has been shown in HFpEF and HFpEF. And then they demonstrated that SGLT2s, including DAPA, have a class 1A recommendation for HFpEF, for HFpEF. And this demonstrates that it is implicated or used in first-line therapy for heart failure. So in conclusion, basically, we noticed that dapagliflozin significantly reduced mortality and hospitalization for heart failure across the range of ejection fraction, and was able to reduce the risk of cardiovascular death by 14%. All-cause mortality showed a relative risk reduction of 10%. And we were also able to reduce the risk for first-time as well as continuous hospitalization for the heart failure patient. So SGLT2s, including DAPA, are recommended for patients in heart failure regardless of the ejection fraction, as we have illustrated from our heart failure with reduced ejection fraction studies as well as the percent ejection fraction studies. And dapagliflozin and ILVEVA as well as DAPA-HF have demonstrated significant benefits of dapagliflozin across the range of ejection fraction. So dapagliflozin is the only SGLT2 inhibitor which has shown clinically meaningful mortality benefits in patients with heart failure, irrespective of the ejection fraction. And it's key in managing our heart failure patients because it's actually part of the guideline-directed management therapies to improve outcomes for our patients. So with this, I'll end my presentation here. I hope I'm within time. Thank you so much for your indulgence.
Thank you, AstraZeneca. I think we will move on to our next topic. That is strengthening primary care to achieve universal health coverage. Quality improvement as the key enabler. And to do this presentation, we have Dr. Afari. Dr. Afari is a member of the college, special interest in safety, quality improvement, health administration, data analytics. But he has been involved with a lot of organizations, the non-applicable Ghana, the WHO, AfriOne, Private Health Insurance Association, and of course, the Ghana College of Physicians Surgeons. Dr. Afari, the audience.
Good morning. Good morning. Good morning. Good morning. It was to catch your attention. Just to test that we are all on. So good afternoon, once again. This afternoon, I'm sure somebody is wondering, does he have a serious slide? Yes, I have a serious. That's exactly what I'm doing. Thank you very much, Mr. Chair, for the opportunity. This afternoon, we are talking quickly about strengthening primary health care to achieving universal health coverage. And the focus is going to be on quality. This will be my outline, a brief introduction, then look at healthcare quality standards towards UHC. Then, of course, some performance across the facilities that my organization works. And then we conclude. Now, the target of UHC was to make sure that we have an all-inclusive healthcare system, whereby, irrespective of whether you have money or not, you have access to healthcare at all times. But most importantly, not just access, but then quality. And we as primary care physicians or family physicians, we have at the helm of what we do, comprehensive and continuous care. Now, healthcare is not just focusing on curative medicine. We are looking also at preventive medicine, promotive medicine, rehabilitation, and palliative care. Now, just to share something with you, in 2018, the Lancet Global Health Commission on Health Quality Systems came up with this survey that found out something very, very disturbing. That in sub-Saharan Africa, and actually in 137 lower and middle income countries, which is affectionately referred to as emerging markets, 3.5 million people were dying annually due to lack of access to healthcare, which I'm sure a lot of us can sympathize with. But the revealing part of the research was that another set of 5 million people, and yesterday at the health summit at Kempinski, that figure has been reduced to 8.4 million people are actually dying, not because of lack of access, but they have access to poor quality. Which actually means that if you are sick and you go to the hospital, you have a higher chance of dying going to the hospital as against you being at home. This is very serious. So our healthcare facilities are now becoming slaughterhouses instead of saving people from dying. And I'm sure we can all empathize with some of these things. When we talk about infection prevention and control, some are saying COVID is gone, but it's not really the truth. Now you wear a face mask and people are looking at you differently. But just a few years ago, face mask became really part of the dressing that we were having on a daily basis. Communication within our system, are people communicating very well? When information which is management, is it able to trickle down right from the head of the facility to quote unquote the gates man? Do we have protocol in place? And when we need protocol, not just papers, but practical protocol. How often are we reviewing our protocols and giving our guidelines? And these are the contributing factors to the over 5 million people who are dying annually in this part of our world due to poor access. And I'm sure these are the dimensions that we can identify with safety, timeliness, efficiency, and most importantly, it used to be 7, but up until recently, the WHO has added integrated. The care that we are giving, are we integrating all these facets to ensure that quality is ensured? And family physicians, of course, patient-centeredness is at the center of our practice. Just by way of definition, the WHO defines quality as a continuous and ongoing effort to achieve measurable improvements in the efficiency, effectiveness, performance, and accountability, and then outcomes, of course, in the services that we provide. But we as an organization take it from the angle that quality improvement is basically a systematic approach that uses specific techniques to achieve quality. The organization I represent is known as Farm Access Ghana. We are a Netherlands not-for-profit organization with country offices in Africa, mainly Nigeria, Kenya, Tanzania, and in Ghana. We also do work in Mozambique, Uganda, and very recently we entered into India, Pakistan, and Afghanistan. Currently, we work in 21 countries, and we have done as many as 7,000 assessments all over the world. When the creative group was speaking, one thing they touched on was the SDG. It is one of the core tenets of the work that we do. Can you permit me to have to rush through because of time? Now, how do we achieve these things? So we use a stepwise approach. First of all, by coming over to a facility, we conduct what we call a quality assessment. We need to know the state where you find yourself as a facility. Then these assessments are guided by internationally accredited standards. So the mother of all quality improvement programs in the world is called ISQA, International Society for Healthcare Quality, where our standards are accredited. Of course, when you do these assessments, you receive a lot of data. So how do you make sense out of the data that we receive? And we use a lot of data analytics and data insight to achieve this. What does the assessment cover? First of all, we have what we call the management bouquet. So starting from governance and management. So things about leadership. Did you know that, let me cite this example, especially in the mission hospital. When you study the organization of their board, management board, you realize that they have more religious people on it than technical people. I was in a facility that had more religious people in there. They had somebody from legal, but there was no medical person on the board. How did I know this? Because I was never invited to a board meeting. There was no medical person but myself. Human resource. How do we make sure that the right mix is present in a healthcare facility? When health professionals are posted to healthcare facilities, how do we ensure that they have the right credentials, do the right work that they do? How do we train them in service training? We do assess that. Patients and family rights, issues of accessibility, confidentiality. Most of us can cast our minds to the consent forms we have in our facility. They are usually one paragraph. But I have sat through a session in the United States where a counseling session or a consent session took more than 3 hours for a procedure that did not last more than 45 minutes. Information management isn't about having an electronic medical record system in place. How do you harness the data that we collect to make sense and to also inform management decisions? Risk management, occupational health and safety issues, fire safety. And if I dare ask, how many of us know the types of fire extinguishers that we have normally in our system? We enter health facilities and extinguishers have even expired and they are beautiful handling there. Then we come to the clinical bouquet. So primary healthcare service. So anything OPD, anything with a C attached. So like ANC, BNC, what again? CWC, I never said NDC. Sorry. Let me add MVPC so that it's balanced. All right. Inpatient services, central anesthesia, laboratory services, diagnostic and imaging. We look at medication management, drug stewardship, facility management, and support services. So these areas are all covered by our assessment. Kindly note that we have different assessment tools for the size of facilities that we assess. We have a tool that is as small as 45 criteria, the highest which is 680 criteria. Let me skip the slide and then go on to the aims of quality improvement. First of all, the aim is to bring us to a level of standardization. Up until the Ghana Black Stars plays against a team like France or the Netherlands, it is deemed as the best country football team. But only when you measure yourself against others, when you are rated and benchmarked against others, then you know your level. Of course, identifying gaps without solutions is just like nothing. So we propose solutions for the gap that we identify. Then, of course, we also look at prevention. Prevention, and then data insight. So quickly, let me take you through some of the results that we come up with. This is from the data from the work that we've done. From 2012 to 2013, we have a facility list of 626 in Ghana. Out of this, the performance is that 84% of our facilities across all networks. So what do we mean by all networks? We have the public sector, we have the private not-for-profit, so like the mission hospitals, we have the private for-profit, so straight private. And this has been the performance so far. Across the service elements that we analyze, the red bar shows the initial assessment that we conducted, and then the blue bar shows. So you can see that there's been market improvement across all the networks. For one of time, maybe I'll just share this with you. Currently in the public space, we are working with Ghana Health Service. We did a small scale rollout with 40 facilities in the Blue East and Savannah regions. And then we came up with this. And for this, the Director General was very excited and thought that we should scale up to national level. For our private not-for-profit, the data is just running through. You can see that the blue bars are doing very well over the red bars. Now, in conclusion, that's a lot of data. In conclusion, we want to say that our current systems actually have a limited performance for evaluation. We have the typical peer review system, but it has turned into a mafioso game. What does that mean? Dr. Niaya's facility comes to assess my facility and mafias me. The next time I go to his facility, and mafias me. So that is what our current peer review system is having. It lacks that objectivity. Now, existing performance also lacks standards. And it's about time that we incorporate internationally accredited standards into our system. Now, in achieving UAC, we talk about access. But the truth of the matter is, whether Agenda 111 or Agenda 5000, we need to think quality. And it is quality, quality, quality. And in safe care and pharmacy, we say that the impossible is possible only when we care. Thank you very much for this wonderful.
Thank you very much. We'll have drop presentation, just 5 minutes. Parties. 5 minutes.
Good afternoon. So I'm very important about it. I like to say that our patients are not only getting access, it's not about access to quality medications. So it is very important the kind of medications that we prescribe for our patients. So this afternoon, I'm here to just open up a discussion on type 2 diabetic patients. But before I just delve into my slides, I just want a moment for us to check in with our patients, just walk in the shoes of our patients. On a very recent visit with one of my cardiologists, I went to the diabetic clinic and I saw a patient whose leg has been amputated as a result of type 2 diabetes. Something that is very, very, very much preventable. And so this is why I'm here offering some of the solutions that Novartis offers in terms of our diabetic patient management to help curtail some of these things and give these patients the best of life without any limitation. So, as Doc said, quality to access. So Galvus and Galvus Med is a brand by Novartis, which has been in existence for over a decade. We have it in over 115 countries with 48 million patient years, with over 200 clinical trials conducted on this. So what this means is that when you prescribe Galvus Med for your patient, it's backed by some scientific data of efficacy, safety, and tolerability for your patients. So these are the various patients that Galvus and Galvus Med helps you or offers you tailored measure solutions for your patients. And these patients are patients that we constantly see in our consulting room. So patient number 1 profile is newly diagnosed diabetic patients. We all do see these patients, right? We also see patients who are on metformin monotherapy who are still not achieving their HbA1c goals. We also see patients who are on insulin therapy who are still not achieving their HbA1c goals. And we also see renally impaired patients who are still not also achieving their HbA1 goals. And we also see our elderly patients as well, who are the most vulnerable when it comes to hypoglycemic effects, which we are most concerned about. And these are some of the things I'll be highlighting with our scientific data. So for newly diagnosed patients, we have a clinical trial which is called Bossitar. And for Bossitar, what we are looking at was the effect of edagliptin, which is Galvus, given twice a day on the drop in HbA1c of these patients. So we can see the mean HbA1c of the patients there, which is 8.6. And this clinical trial was conducted over 24 weeks. And we realized that for patients which we put on a Galvus BD as monotherapy, we get a drop of -1.1. For patients who were put on metformin monotherapy from the same baseline, we get a drop of -8.6. And for patients who were put on dual therapy, we had for the low dose Galvus, which is 50 milligram edagliptin and 500 milligram metformin, we had a drop of -1.6. And for those patients who were also put on the 50,002, we had a drop of -1.8. So the interesting thing and the detail about this clinical trial that we discovered is that the higher the HbA1c value, the greater the drop. So we even had patients who were coming in with HbA1c of greater than 10, where we were getting drops of as high as 3.2%. And straight glycemic control is always and always be the sure way when it comes to management of diabetes. Because if you get the basics right, you go a long way in terms of avoiding and preventing these complications. Okay, so another gap we also see is the progressive decline of beta cell function when it comes to the management of diabetes, which Novartis addressed very well with our drug, which is Galvus Med. So this is another clinical trial for newly diagnosed patients, which was more centered on the time to treatment failure by the Verify study. So we have two groups of patients. We have patients that we started on monotherapy with metformin, and then we had another group of patients where we started on dual therapy with Galvus Med. To see between these two groups of patients over the 5 years period, which one will have a more lasting time or a prolonged time in terms of treatment failure. We realized that for the patients where we adopted the new approach of dual therapy with Galvus Med, we realized that these patients had extended 2 years of preserved, which accounts for preserved beta cell function, which shows that they have an extended 2 years before treatment failure. So we are saying that how you start your patients or your newly diagnosed diabetic patient is very, very important to whether how soon the patient is going to be on insulin, which we know the non-adherence and the issue of hypoglycemia that comes with insulin. And Galvus Med, initiated for your newly diagnosed patient, is the sure way to And so this is just a data to show the improvement of the beta cell function. This is a comparative study where we were looking at galvus as an add-on to patients on metformin monotherapy who are not doing so well. And we compare this with an active molecule, which is Ilmepride, as high as a dose of 6 milligrams. At the end of the clinical trials, these are some of the stipulations we find. We realize that in terms of efficacy, galvusmet given at 50 milligram BD, that is in combination getting your galvusmet, gave you comparable efficacy as that of the Ilmepride as high as 6 milligrams, which most of us physicians do not really attempt to go there because of the incidence of hypoglycemic control. The interesting thing we find out was the incidence of hypoglycemia, which was associated. We realized that there were high incidence of hypoglycemia for the patient who were put on Ilmepride, as high as 10 times as compared to patients who got Smith. So what does all this data translate into for our patients? And this is and I'll be ending very soon. So this is going to be probably my last slide. So very soon, my last statement. And I want us to be with me for just a moment. So what does this all data that I'm sharing resolve or relate to for our patient? This is a UK PDS trial. We see that a 1% drop in HB1C accounts for a 37% drop in microvascular complication. That is retinopathy and also kidney-related diseases. We are also saying that it reduced the risk of amputation for your patient by 43% and also reduced the risk of death related to diabetes by 21% and risk of heart attack by 14% and risk of stroke by 12%. So it is very, very important for us to understand that getting your patient to achieve their target HB1C goal is very important if we are looking at mitigating some of these cardiovascular diseases that comes with diabetes. And the sure approach is how we start for your patient, we leave that patient that legacy that will last the patient the while. So in conclusion to my presentation, so that's galvus, the plain galvus, which we can use for our special patient, that is for the renal impaired patient, even up to end-stage renal disease. Just a 1 daily dose can deliver an HB1C of about 0.9%. And then we have the galvusmet, which comes with various doses of 5,500, 5,850, and 50,000, with no concerns of hypoglycemia. You can gladly give this drug to your patient and get the level of efficacy that you want for your patient. So thank you very much for the opportunity to be here. Thank you.
Thank you very much. Now we are going back to the presentations again. The next topic is breast cancer screening experience in a developing country. And for our resource person, we have Dr. Abba Akurugu. Now, he is a member of the Ghana College of Physicians Family Medicine, and he started training in fundamentals of global health, research, and also in leadership and management in the University of Washington in Seattle. He is the lead clinician for training. He is also the lead physician for asthma, pediatrics, and detention services at the Tamale Teaching Hospital. Dr. Akurugu. Over to you. Good afternoon. Before I start I want to acknowledge that the screening exercise was made possible through the funding of support. This was the first one we did at the Tamale Teaching Hospital Polyclinic. And the mentor who has helped me to do this study is an associate professor of orthopedics, Professor Alexis. I'm the principal investigator and the corresponding author. The three, my boss and one of the residents, they are here with me. So the background to the study, breast cancer is one of the commonest cancers among women, and Ghana is not an exception. One of the biggest problems in Ghana is that they present late in advanced stage. And from the National Cancer Strategy for Cancer Control, they indicated that about 50 to 70% of them would delay 8 to 10 months before coming to the hospital. But there have been studies in many countries which indicates that if you get the early signs and symptoms of breast cancer, or if screening detects breast cancer early, the outcomes are good. The more breast preservation surgeries can be done, and then the psychosocial problems that are associated with breast cancer as we have it now is going to be reduced. So as a country, where we are is not the best for our population. And it is also found that from the National Strategy for Cancer Control, the age that is stated there is that as young as 20 years has been reported to have breast cancer. And we are having increasingly younger population, economically active women being diagnosed with advanced breast cancer. And there have been a number of researches that have been studied across the country, and it shows that there are financial problems, psychosocial problems, depression, the complications and side effects of the treatment. So the fact that we have low self-breast examination, clinical breast examination, mammography doesn't exist with the increasingly younger population made us to think of this study that we did. Can we look back and then study to find out whether, even if we have one opportunity, can we maximize it to get the best outcome? But it is noted that early detection and strategies that will make you find breast cancer that come with smaller sizes improve outcomes. There have actually been studies in Brazil and other nations that shows that if it doesn't on the last reference is sorry. So that is what informed us from doing this study. And the objective of the study was to describe the demographics, the best problems that we found in the screening, and the predictors of participation, as well as factors influencing participation. And what among the parameters that were available, what were the parameters or the variables that were associated with finding abnormal breast findings in the patients. Then we also
decided to find out the source of information. It is known that if you are able to give patients information and inform them, clinical breast examination comes with increased investigations. And it has been said to be a disincentive because you will tell people to go and do screening, whether mammogram or ultrasound, and then the finding will be benign. So there will be increased costs, and there's also the tendency that they will have, the fact that you are telling them, I have found a lesion, it impacts them psychologically. But so if we can get them informed, we wanted to know the source of information, where did they get information from, and that influence their participation and its implication for future screening. Because if you have less resources, you should focus on what can help you get more of them to come. The other one that we wanted to find out was the thing that we did. If you get an opportunity, the annual breast screening that happens in almost many places across the country in the month of October. What are the innovative strategies that we can adopt that can give us more outcome or better outcome? So just as I said, the materials and methods, it was a retrospective descriptive study on the breast screening that was sponsored by SOFPOC in October 2023. 23 trained staff did the clinical breast examination for 10 days. It was 10 days because of limited resources. And we had 4 TV breast awareness campaigns, 2 radio, and a total of 574 people were screened. And there were those who met the inclusion criteria where we were 335. If there was the variables that we wanted to use to analyze, if there was a complete information on all those variables, then you were included. If there wasn't complete information, we will exclude you. That is how we use, and we use a structured questionnaire to extract the data from. There was a register that was used, the scan results, then reports that were available that we could use to extract the information. The data was entered using a GraphPad present version 5, and frequencies and percentages were computed using Excel. We decided to make sure, because it's a descriptive observational study, confounding is a very common problem that might not make whatever finding that you have become the real presentation. So we had to do multivariate logistic regression for the prediction of breast abnormalities of the various variables that we use. The variables were the age ranges. We decided to categorize them into from 15 to 24, and from 24 to 39, 40 to 65, and above 65. And the reason why we did that was done because the Ghana strategy for cancer control says breast awareness campaigns should be done as early as 16 years, and screening should start below the age of 35 years. So we wanted to know whether the population that we would have, would this population be significant? And we also did chi-square analysis to determine the factors influencing the participation. Then the results that we had, out of the 535 that were analyzed, the age group 25 to 39, the early presentation that is being identified in Ghana, they form the largest population, followed by the age group 40 to 65. And 71 of them were urban dwellers. Then 67 of them had the screening from mass media. But from chi-square analysis, it was not related with the decision to participate. In all, we had 25 breast abnormalities found, 1 tubular
carcinoma without distant metastasis was found. At the moment, that patient is doing adjuvant chemotherapy. Then the age was 40 years. Then when we did the multivariate logistic regression analysis, we realized that those variables that were significantly associated with the detecting breast abnormality were in this age group, 25 to 39. However, they were all benign cases. The one who had the malignancy was 50 years. Family history was also significant. So that means that if we are doing and we are deliberate in trying to use innovation that can let us know that this person have a family history of breast cancer, we can follow them up, pick the breast problem early, and that can let us get to the better outcome that we want to find, even if it is just one screening. Then the participants that also had painful breasts, so the lesions that were found, we have breast fibroadenoma, breast abscess, a cystic or dark ectasia. They were the major benign findings, and they were associated with high adjusted odds ratio, just as I've said. So the chi-square analysis that we did for the various variables, we detected that there was a significant distribution among the age groups that I've already mentioned, whether you had a high-risk status, family history, if the patient had used oral contraceptive more than 10 years, and if you also had a personal history of breast cancer, there was a significant distribution from the chi-square analysis. The type of breast cancer was also significantly, there was a significant distribution that made people who came for the participation. There was a significant distribution. But like I said, though as high as 67 people had the awareness campaign that we did through the TV and the radio, they heard it from that one, and fewer people heard from family and friends. It did not inform the decision to participate. In conclusion, though it was a short few days screening, and the population that we had, the 535 that we analyzed, is not a larger population to generalize for the whole population. But what we can say about those few days and the level of participation is that there's a higher or increased popular participation in breast cancer. You've seen what we had from our screening. The mass media is also effective too if we want to increase breast awareness campaigns wherever we are doing it. Then we also found out that if we are having increasingly younger age having breast lesions who delay up to 8 to 10 months before they present in advanced stage, from our cohort, we had a larger population between 25 to 39. So whether it is an annual breast screening program, whether it is an institution or agency or an NGO initiated breast screening, we are likely to improve the outcomes that the National Strategy for Breast Cancer Control intends to achieve. So it gives us the motivation that when we are doing it and we do it with some level of innovation, we can help detect them early. Thank you. That was fast. Yes, we will have the last clinical presentation for the day, and then we'll top it with the representation. Now, the next is on the prevalence and determinants of abnormal colposcopy, findings at the Kolbu Polyclinic. Now, Dr. Ayongo Anna is going to do this presentation. She is a member of the West African College of Physicians, at the polyclinic. She's in charge of the women's clinic and is a member of the training and research team at the polyclinic, Dr. Ayungo Clinic. Ayungo, and sorry. We're getting to the end of the day.
Good afternoon to you all. I'm very grateful for this opportunity. So as Dr. Aya mentioned, Ayungo Anan, Ayungo Matekole, the same person. So this is my team for the research that we did, and I'm the one doing the presentation. So the topic is prevalence and determinants of abnormal colposcopy findings at Korle Bu Polyclinic Women's Clinic. So this is the presentation outline, introduction, methods, results, discussion, and then the references. So by way of introduction, cervical cancer screening and evaluation remains the hallmark of cervical cancer prevention worldwide. Cervical cancer is a significant public health problem globally, and in Ghana, it's a very, very important topic. It is the second most frequent female cancer in women aged 15 to 44 years, and in Ghana is the leading cause of cancer mortality in women. Visual inspection with acetic acid, pap smear, and HPV testing are the primary screening modalities used in Ghana for cervical cancer screening. Colposcopy is usually used for further evaluation of those who are positive for the VIA pap or the HPV test, and is used to identify cases with true cervical dysplasia for treatment and biopsy. Though this is a very valuable service, that is a colposcopy, and can be done by trained medical personnel, including nurses, is not available in most centers in Ghana. This study aims to analyze retrospective data from colposcopy services at the Women's Clinic from 2015, since its inception, till 2022, evaluating the prevalence and factors associated with abnormal colposcopy findings in women attending the Korle Bu Polyclinic Family Medicine, KPFMD Women's Clinic. The method. So the study reviewed secondary data from women's clinic registers and data sheets from 2015 to 2022. Data included information on patients who were referred for colposcopy for after positive VIA or pap test, and the participants were women, included women 18 years and above who underwent colposcopy. So Korle Bu Polyclinic Women's Clinic was established in 2015 when a British trained obstetrician gynecologist, Dr. Pepra, came to Ghana to train a couple of us in colposcopy. So a colposcope was procured, and then the service was started. The services provided currently are breast examination, cervical cancer screening using VIA, pap smear, and HPV testing, and then colposcopy. We know this is not a full complement for what should be done in a women's clinic, but it's a start, and we hope to enlarge our course as we go along. So this is where it all began. This was the training sessions we had, Dr. Van Dyke in the picture, myself and Nurse Adugu, we started with. That's Dr. Pepra. So we're looking at some, she was teaching us, taking us through colposcopy training. Now, this image just tells us some of our activities. Recently, this January, we had free VIA screening in collaboration with Medical Women's Association of Ghana and it was at the polyclinic. So this was a session where we were educating them prior to the screening. This is the women's clinic team. As you can see, it's not a full complement though. Sometimes we are joined by Dr. Susan Keteku and then Dr. Ajua Beecham. And we have one male member, Dr. Alfred Cedar. He also joins us as and when he's available. So data was captured in Microsoft Excel 2016, transported to SPSS version 25 for analysis. Frequencies and proportions were used to explore socio-demographic characteristics and colposcopy outcomes. Continuous data was expressed as mean plus or minus standard deviation. Chi-square and multivariate logistic regression models were used to compare and assess the factors associated with abnormal colposcopy findings, and the p-value was set as less than 0.05. The results. So we noticed, or we had that a total of 218 people, and the greatest number of people were below 60 years of age. As you can see from the marital status, majority of the women were married. Educational level, most of them had attained tertiary education. And then occupation, most of them were entrepreneurs. The colposcopy outcome, 17.9% had abnormal colposcopy findings, and then 82.1% were normal. Now, for this, when we assess for the factors associated with abnormal colposcopy findings, we realized that it was only age that had an independent association with abnormal colposcopy findings. Discussion. So the age range of those who had colposcopy was from 21 to 77 years. Majority of them were below 60 years. Almost 60% were married, and this is not surprising, as cervical cancer screening and evaluation is recommended for sexually active women. Among the women who underwent colposcopy, 17.9% had abnormal findings. And this means these women were more likely to have cervical dysplasia. The prevalence of abnormal colposcopy found in this study was lower than what was found in a study by Ifa et al. In 2022 at Bato in the Volta region. They found 30.2% abnormal colposcopy findings among women referred for colposcopy after positive HPV, PAP, and VIA screening. Now, this is not surprising, as several studies have demonstrated high false positive results in VIA and PAP smear. This study found age to be independently associated with abnormal colposcopy findings. Women aged 60 years and above had a 5-fold increased odds of having an abnormal colposcopy finding compared to those who were below 60. Studies have shown that older age groups are more likely to have higher incidence and mortality rates of cervical cancer. A study in both Greater Accra and Ashanti regions of Ghana showed that the incidence of cervical cancer increased with age of women from these regions. We find from 70 to 74 years in Greater Accra and 75 to 79 years in the Ashanti region. A similar trend was reported in this current study, where elderly women 60 years and above were more likely to have abnormal colposcopy finding. Quick et al. Also found that cervical cancer incidence rates were greater in older women than in women who were under 65 years, with Black women having the highest incidence rates. The limitation of this study was that this study was a retrospective study, and some key variables were not measured. Despite this limitation, this study is a good baseline that would be a prerequisite for collecting primary data in future studies. In conclusion, this study not only reaffirms the high prevalence of false positive VIA and PAP smear among women, but also tells us about the critical role of age in influencing cervical cancer screening outcomes. It also emphasizes the significant impact primary care, especially family physicians, can have in enhancing and improving patient screening outcomes through colposcopy. These are my references. Thank you very much.
Thank you very much. Dr. Ayongo Matikole. Right, now we'll call Tridem. Are you ready? Yes, we'll give you 7 minutes to do your presentation.
All right, good afternoon, everyone. My name is Michael Clotte. I'm a pharmacist and I'm a Tridem farmer. And this afternoon, I'm privileged to be here to introduce to you the new artesunate injection with a single solvent system. Now, before I proceed, you are already familiar with the artesunate on the market, and you agree with me that when it comes to artesunate injection, Tridem Pharma is the innovator for artesunate injection. Now, according to the World Health Organization, severe malaria is a medical emergency. This is to mean that at any point in time when diagnoses have been made and you have confirmed a parasite, according to the WHO, you are supposed to give the most effective parenteral anti-malaria that is readily available without delay. And looking at this, it means that time is really of the essence in the management of patients with severe malaria. Now, imagine you have a patient who comes to the hospital, and this patient is a very hardworking individual who aspires to be a family physician one day in the future. Then this patient comes down with severe malaria. Then during the process of reconstitution, the life of that patient is lost. Just an imagination. Just an imagination. All what I'm trying to say is when it comes to the management of severe malaria, time is of the essence. And because time is of the essence, Tridem Pharma, as the innovators of artesunate injection, want to transition from just having a 3-valve artesunate injection to a single solvent artesunate injection, so that at the end of the day, we are going to have a reduced reconstitution time. And in a nutshell, it's going to make it easier to prepare, it's going to make it faster to reconstitute, and it's going to make it safer to administer artesunate injection in the management of patients with severe malaria. Now let's delve deeper into this molecule. So now Tridem Pharma has upgraded from the 3-valve artesunate injection called Artesan, which is the innovator brand, to a 2-valve artesunate injection called Artesan. and we are still innovators of artesunate injection. Now let's do a little comparison. Now what you know is the conventional artesunate is partially soluble, and for that reason we add the bicarbonate to form a salt of the powder. Then we can now add our sodium chloride to the solution to make up to volume. Now in the conventional artesunate injection or the 3-bar artesunate injection, Artisan allows you or affords you 3 minutes of reconstitution time. But what if I tell you that we can still reduce the reconstitution time to the barest minimum to save the life of the patient? And that is how we have transitioned to the upgraded one called Artisan. So Artisan comes as a single solvent system. So the one I showed you earlier on was a 3-bar, but here we have 2 bars. So you have the powder and you have the solvent, which is a single solvent system having a mixture of sodium bicarbonate and arginine solution. Now in the conventional artesunate injection, now what you have is we have 3 strengths. We have the 30 milligram, we have the 60 milligram, and then we have the 120 milligram for the 3-bar artesunate injection. But when it comes to the new artesunate injection with a single solvent system produced by Trident Pharma, we have 4 strengths. We have Artisan 30, we have Artisan 60, we have Artisan 120, and we have the additional strength, Artisan 180. So we are the first company to have the strength 180 milligram of artesunate injection on the market as well. Now, in the conventional artesunate injection, which is the 3-bar, when it comes to the IV, you can give it either by IV route or IM route. The IV route is the preferred route. Now, when it comes to the IV route with the 3-bar, you go with a concentration of 10 milligram per ml. But when you want to do an IM, you go with a concentration of 20 milligram per ml. So at a point where a patient has been diagnosed, parasite confirmed, and then you think you are going to give an IV medication, you prepare the solution only to realize you can't find a vein. That becomes another problem. So what are we doing? Trident Pharma is trying to be highly innovative enough to make sure that you can have one volume that will cater for both IV and IM. And that is what Artisan is doing. So the Artisan that we have has a concentration of 20 milligram per ml. And this 20 milligram per ml allows you to give the product by both IV and IM. So where you do your reconstitution and you don't find a vein, by that same volume you would have injected for IV, you can inject that same volume for IM as well. Now, when it comes to the 3-bar artesunate injection, you agree with me that for the strength that we have, if you have Artisan 30, which is the 3-bar, when you do your reconstitution, you get a total volume of 3 ml. When you do the 60 of the 3 bars, you get 6 ml. And when you do the 120 milligram, you get 12 ml because the concentration is 10 milligram per ml. But with Artisan, because the concentration is 20 milligram per ml, the volume for which you inject your patient is now halved. So at the end of the day, if you have Artisan 30, your total volume becomes 1.5. If you have Artisan 60, your total volume becomes 3 ml. Artisan 120, total volume becomes 6 ml. And Artisan 180, total volume becomes 9 ml. So that helps you to save syringes as well, because at the end of the day, you need smaller volumes to inject this patient with as well. So the dosing of artesunate has not changed. It's still dosed for children who are less than 20 milligram will be dosed at 3.0 milligram per kilogram, and those who are above 20 kilogram will be dosed at 2.4 milligram per kilogram at time 0, at time 12, and at time 24 hours. So this is what I've been talking about. So the volumes are reduced. The 30 milligram will have 1.5, 63 ml, 126 ml, and then 180 milligram, 9 ml. So just to do a little exercise, because it's a new drug in the system, I just want you to have a feel of it. It's still within my time. So I'll just give some samples, you can pass it around. So this is just pass it around. So we can just pass it around. So this is just to enable you to have a feel. How many minutes do I have? I have 2 minutes. Yeah. So just pass it around for me. So this is the new generation, this is the new artesunate injection with a single solvent, and I want you to have a feel of it. Now let me be quick. In the management of severe malaria, according to the World Health Organization, there are 4 steps First, you do your parasite confirmation, you weigh your patient, you give your injection adjuvant, and then you give a full oral ACT. Now, my argument will be, which oral ACT will you consider ideal for your patient after you have treated them with artesunate injection? Now, a patient who is being given artesunate injection, trust you me, the artesunate injection is like a prodrug, and the body will have to convert it into dihydroartemisinin. And dihydroartemisinin, DHA, is the active ingredient that clears the parasite. This is to mean, in practice, as family physicians, when you give your patient cephalosporin injection, you discharge your patient on cephalosporin tablets. So in that same vein, if you give your patient artesunate injection, adjuvant, and the body has converted to DHA, then it is appropriate that in switching your patient to an oral tablet, you want to give your patient a drug or an oral tablet that is already in the DHA form. Now, a patient who has been admitted with severe malaria is a candidate for another bout of severe malaria. And we are looking for a molecule that will not just treat the patient for 3 days, but a molecule that is reasoning beyond the 3-day conventional treatment of malaria and thinking of how the patient could be protected systemically for a period of days so that at any point in time, the same patient will not come to the hospital several times or multiple times for the management of malaria cases. And in this light, I introduce to you our oral ACT of choice for the management of malaria, Diatep. So I believe most of you know about the drug Diatep. It has 2 active ingredients, dihydroartemisinin and piperacin. The dihydroartemisinin provides you with a rapid onset of action, and the piperacin has a prolonged elevation of life, protecting your patient up to 63 days. So once you take Diatep, you know you are rest assured for protection. The dosing of Diatep is simple. We have 4 different strengths of Diatep. We have Diatep 20, Diatep 40, Diatep 60, and Diatep 80. I'm using the DHA strength. The Diatep 20 and 40 are for kids and is citrus flavored. And then the Diatep 60 and 80 are for adults. So for those who are about 35, we give them Diatep 6480, and it's 2 tablets daily for 3 days. Initially, we had just 1 strength, 4320, but now we have categorized the strength, making it simpler. So anyone about 35 kilograms, but less than 60, will go for the Diatep 6480, and it's just 2 tablets daily for 3 days. And for those who are above 60 kilograms, we dose them Diatep 8640, and also 2 tablets daily for 3 days. I asked myself, why will somebody above 35, somebody around 100, and somebody around 35 be taking the same dose when you are claiming a parasite? There's a need to provide a more accurate dose in which Diatep is providing for you. So instead of saying everyone above 35 take Diatep 60, we created a new dose, which is the Diatep 80, to help cater for those at the extreme weight end and have a better clearance of the parasite. Ladies and gentlemen, in summary, all I've been saying is that when it comes to the management of severe malaria, it shouldn't be taken lightly, and time is of the essence. And for that reason, there's a need for, a transition, so that we can have a reduced reconstitution time and save the life of the patient. And in that light, we have introduced to you adjuvant, which comes as a single solvent system and has a reconstitution time within 1 minute. And once you are done giving your artesunate injection, switch your patient to no other oral ACT than Diatep. Thank you very much.
Thank you very much. He added a minute. We'll prepare a fine for you. Thank you. So we will do a discussion on the presentations which have gone on in the second half. Still a reminder, the slides will be available. The exhibitions are still going on. So discussions, questions, suggestions. Should I set my timer to close the discussions? So 5, 4, 3. Okay. Yes.
Thank you very much for the opportunity. About the 2 presentations, right? That is what we're talking about. I want to thank both presenters for their information. Dr. Joshua, I just want to make a comment on yours. It's excellent
results. And I want to say that when you were able to get abnormal results in the women, that is okay, but don't say only one cancer. So take away the only, please. Thank you so much.
Thank you. Any other comments? Okay. Yeah, before the housekeeping activities, I must take this opportunity to thank softball, especially for giving me the opportunity to do this marathon. I survived. In the audience, your forbearance has been phenomenal. The presenters, and I'll use the word erudite presenters, it's been very eye-opening. Now, we've gone through topics about research studies, and it runs through, all of them are about collaboration. In fact, I was introducing the lead of the teams, but you saw it, every team had a group of family physicians who were involved. It is very interesting that we also stress the issues about SDG 3. And the CREATE team was very exciting. I was telling them that I wish the doyen of research into cardiometabolic metabolic and cardiac diseases in Ghana, that's Professor Silas Dodo, was alive. Of course, there are others who are still there. Professor Moa is dead, Professor Usu is there, the younger old men like Professor Fair, they are all around. Yes, now it is no more a time bomb. It's actually a bomb, and it's exploding in our faces. The issues about the cancers. Of course, we are the front line, and if we are going to make noise about seeing them late, then it means we are failing in our responsibilities. We've been shown simple studies which will help to check this. Now, for the teams, don't feel disheartened. It's a first line, it's a first time, and for family physicians, I'm encouraging everybody, look for somewhere to see behind the lines. The Ashantis will say, "Se ofi we are near se obehu samai." This one you see samai, you see knowledge. Thank you for the opportunity. Thank you very much.
Thank you very much, Chair, patron for the society, and my mentor. Really appreciate your officiating this section. Support, I don't know what slogan we need to use, but when I say family physicians, I mean, who is going to know the... Thank you, family physicians. Family physicians. Okay, so thank God, and as we all know, it's our 10th anniversary. So we thought it wise to have something nice for all of us. At least if you have it as a key holder and you are served drinks, I'm talking about fresh food drinks, please, and not healing. Then you can have this to open, the bottles. And anytime that you're going to open your car, or you open your door of your house, you remember that yes, support is indeed 10 years. You are going beyond it, you are going to have more impact. So this is something nice for all of us. Everybody is going to have one. And remember that we are 10 years and we need to impact more. What are we going to clap for me? It's very nice. For me, it's the nicest I've seen over the period. I don't know about you, but let's have it. And when we go home and I meet you and you don't have it on your key holder, please, you'll be queried and sacked from the society. We are actually to promote the society as well. So God bless us all. I mean, just before we go for lunch, I hope everybody has gotten their ticket. It means that you are not going to have lunch. I mean, some people have to fast, some have to eat. So if you have not gotten a ticket, it means, I mean, when we balloted, you were chosen not to eat this afternoon. But if you don't have your ticket, please lift up your hand. Dr. Shimako would reach out to you. But before we close, we want to ask Dr. Bandache to give a very quick announcement.
Thank you very much, President. Please, can I have your attention? All right. So, as you are aware, Kolebu Polyclinic Family Medicine is the only WACP training center for family physicians. And in times past, efforts have been made to try and expand that, but it's been challenging. But the issue is that we currently have a new WACP curriculum for both the membership as well as the fellowship level. And we have one of the faculty in Nigeria who has agreed graciously to take all trainers, whether you are Ghana College or WACP, through the new curriculum. And it's been slated for the 29th of May at 3 p.m. and it's virtual. So please, especially our trainers, chief residents who are here, and residents who are here, make sure you join, because a lot of us are not sure exactly what the new curriculum is about. We all have our questions. Come, let the information be provided and you ask all your questions, because we also know as little as you do, but there's an opportunity for us to be educated. So please, this is just a quick announcement. Thank you.
On this note, every chief resident here, please, do contact me after this meeting so that we can coordinate this and put it better. All the chief residents here, if your chief resident is not here, kindly send a message to the chief resident to get in touch so that we can coordinate this better. So thank you very much. On this note, we bring the scientific section to a close. We are having lunch at the restaurant down there, not where we had. It's a place that is allocated to us. So Dr. Sepako will take us there. She will lead us there. And please, if you don't have a ticket, this are group, we are very strict. If you get there, there's a big guy standing there who bounce you. So if you don't have a ticket, kindly get one from Sepako. On this note, I want to say a very big thank you for your forbearance and staying through with us. We are coming back at 4. We are coming back at 4 for the AGSM, the annual general meeting at 4. Please, let's all come. It's our society. We need to discuss. You need to know how our finances are going. You need to know what has gone on over the year. There are a lot of things that we need to share together and plan together. So let's meet here exactly at 4 so that we can close early today and have some time for ourselves today. Thank you very much.
Hello, please, the coupons, the lunch coupons, you need to show it for you to be served. Let's go by the order. Those who don't have the coupons, don't worry. We would give you one there. So, and please, send those who will not eat but have the coupon, they should bring it so that I can give it to other people. Those who are fasting. Thank you very much. It's time for lunch.
Okay.